We'll have it. And that's an excellent idea. Congratulations to the participants. Now we have a first prize also and a second prize also.
Not second prize, runner-up.
Runner up. So we are going live now. So over to you, the organizing committee, Dr. Neha Sinha, Dr. Tanveer Singh, Dr. Neha Mishra, and Dr. Nitin. So over to you.
Thank you, sir. A very good evening and a very warm welcome to all of you. We are thrilled to welcome you all to the final round of RSACP Youth Conclave. It's an absolute pleasure to see so many talented and passionate young minds gathered here today. RSACP is proud to host this event, which has been a platform for aspiring young professionals to showcase their skills and knowledge in the field of anesthesia. Without further delay, let's get started. It is with great honor and immense pride that I take this moment to welcome Dr. Naveen Malhotra, sir, President RSACP National and Youth Conclave Program Head. Sir had been instrumental in bringing forth this brilliant idea of Youth Conclave. Sir, your vision and leadership has provided a unique platform for young minds to come together, share ideas, and grow. Your tireless efforts in shaping the future of our field is truly commendable. Thank you, sir, for inspiring us with your passion and dedication. Please welcome, sir. With great honor, I would like to welcome Dr. Vishal Singla, sir, Honorary Secretary, RSACP National. Sir, your leadership and dedication has been instrumental in shaping this platform that brings young minds together to share ideas and ignite meaningful change. Our sincere gratitude to you, sir, for your unwavering support and dedication to make this event a reality. Please welcome, sir.
Thank you very much, ma'am.
Yes, sir. With great honor and pride, I would like to welcome Dr. Tej K. Kaul, sir, Patron RSACP National. Sir is ex-HOD Dayanand Medical College, past President North Zone ISA, past Editor-in-Chief JOACP, past President RSACP National. Sir, your support and guidance had been instrumental in driving force in shaping our conclave. Please welcome, sir. I also welcome Dr. Neha Sinha ma'am and Dr. Tanveer Singh sir, RSACP Youth Conclave National Coordinator, and Dr. Nitin Chaudhary sir, RSACP Youth Conclave State Coordinators. They are the driving force behind this powerful platform of engagement and collaboration. Before we proceed further, I request Dr. Naveen Malhotra sir to please speak few words and give his blessings.
I'm really very happy today that the dream which we have in our mind to have the youth conclave. Today we are hosting the finale of 2025 Youth Conclave. I am so thankful to Dr. Tanveer Singh, Dr. Neha Sinha, Dr. Neha Mishra, and Dr. Nitin for pulling this off. And we have multiple rounds from different states in all parts of anesthesiology, including academics, clinics, research, work-life balance. And you all are the finalists. I wish you all good luck, and there is a good prize for the winner. We will be the youth orator at the 2026 conference at Indore, and now will be having a runners up also. And whatever Dr. Tej K. Kaul says is a blessing for all of us, and God bless you all. We are always there. The whole RSAP team, the Research Society of Anesthesiology, is always there for the betterment, upliftment of the youth. You please excel with your vibrant energy, enthusiasm, and become successful anesthesiologists, successful pain physicians, successful critical care specialists, and shine in each and every field of anesthesiology. God bless you all. Thank you very much, and best of luck to all the participants.
Thank you, sir. Now I request Dr. Tej K. Kaul, sir, to please speak few words and give his blessings.
Good evening, everyone, and welcome to this RSA Youth Enclave finally. I don't think we need to speak anything more, but just welcome everybody and wish them all best of luck. And we start with our work. Thank you very much.
Thank you, sir. I request Dr. Vishal Singla, sir, to please speak few words and give his blessings.
Good evening, everyone, and my regards to our President, Dr. Naveen Malhotra, sir, our patron, Dr. Tej K. Kaul, sir, Tyra, Dr. Sunil Sethi sir, and all the delegates present. Thank you to each and every one of you for being here with us today. This is a proud moment for Research Society of Anesthesiology to conclude this series of Youth Conclave, to which has given a chance to showcase their work for the youth. I would also like to thank our national coordinators for Youth Conclave, Dr. Tanveer Singh, Dr. Neha Sinha, Dr. Nitin, Dr. Neha Mishra, for all the hard work they have done to make this project a reality. I would also like to take this opportunity to welcome you all to National and International Conference of RSACP Con 2026 to be held in Indore on 12th and 13th April. Please join us. Every one of you is welcome, and please join us in Indore. Looking forward to see all of you in Indore 2024 RSACP Con 2026. Once again, I would like to thanks each and every one of you for being here today. Thank you very much.
Thank you, sir. Now we will proceed with the session. I'm pleased to invite Dr. Naveen Malhotra sir, Dr. Vishal Singla sir, and Dr. Tej K. Kaul sir as our esteemed chairpersons for today's session. And now I would like to invite our first participant, Dr. Bhushanam Badala, to please give his presentation.
Okay, ma'am. Am I audible, ma'am?
Yes.
My screen
I
is
hope
visible.
I hope every participant knows the time. How much time? Kindly tell them about the time.
Okay, sir.
So everybody will be getting a time of 7 minutes for presentation and 2 minutes for question and answers round. So at the end of 6.5 minutes, you'll get a reminder that 30 seconds more are left.
Shall I start?
Good.
Please start.
Okay, sir. Good evening, respected chairpersons and judges. My title of my presentation is Comparison of Intravenous Dexmedetomidine and Lignocaine in combination with parasternal intercostal block on postoperative analgesia in adult patients undergoing cardiac surgery. It is a randomized prospective study. Cardiac surgery is often associated with more severe postoperative pain requiring lots of opioids. So we need to explore and evaluate adjacent therapies that can reduce the perioperative opioid consumption. Parasternal intercostal block has gained attention in the era of ERAS, and dexmedetomidine and intravenous lignocaine has been used in various studies. Coming to the primary objective, my primary objective is to assess and compare the effect of intravenous dexmedetomidine and lignocaine.
Please unmute yourself.
Dr. Bhushanam, please unmute.
Dr. Bhushanam, please unmute.
Am I audible?
Yeah.
On postoperative analgesic requirements in patients undergoing cardiac surgery. My secondary objectives are to compare the duration of postoperative mechanical ventilation, postoperative visual analog score, pain scores, and intraoperative postoperative hemodynamic stability. It is a single center prospective randomized controlled study done over 18 months in a tertiary care teaching hospital. My inclusion criteria are all adult patients aged 18 to 65 years undergoing electrocardiac surgery through median sternotomy and requiring cardiopulmonary bypass who are willing to participate in the study. Exclusion criteria: patients with preoperative cognitive dysfunctions and preoperatively on mechanical ventilator or IABP, or history of previous cardiac surgery, low ejection fraction, allergic to study drugs, and chronic liver renal diseases, or patients with baseline heart rate less than 45 beats per minute. Institutional ethics committee approval was taken, and the study was prospectively registered in the CTRI. And written informed consent was obtained from all participants, and they are also educated with the use of patient-controlled analgesia pump, PCA pumps, and VAS scores for assessing postoperative pain. And standard pre-medication and fasting guidelines were followed, and all patients received standard general endotracheal cardiac anesthesia. This is how parasternal intercostal block was given. a total of 40 ml in 10 spaces, 5 on either side, starting from the second to sixth intercostal space. Parasternal and intercostal block was given in 4 ml aliquots in 10 spaces, total constituting 40 ml. Panel A describing this X marks describes the point entry points of needle, and blocks were given ultrasound guided out of plane. Here we can see in the panel C the drug deposition between third and fourth rib at the junction of lower border of the upper rib, that is third rib, and pleura. As the drug is depositing here, the pleura is indenting downwards. And it is a computer randomized study, and block randomization was done with computer generated random number table with sealed opaque envelope techniques. Measures were taken to ensure all IV syringes containing study drugs were looked identical. There are basically 3 groups: PD, PL, and PS. PD group patients received parasternal block along with dexmedetomidine loading dose of 0.5 microgram per kg over 15 minutes, followed by 0.4 microgram per kg per hour. Whereas in PL, parasternal block followed by lignocaine preservative free loading dose of 1.5 mg per kg over 15 minutes, followed by 1 mg per kg per hour infusion. Whereas in PS, parasternal block followed by saline infusion for blinding. And hemodynamic response, defined as either heart rate or mean arterial pressure more than 20% from baseline, was treated with a bolus dose of intravenous fentanyl 1 microgram per kg. At the end of the surgery, infusions of the study drugs were discontinued and patients were shifted to cardiac ICU. And pain was assessed at the time of first spontaneous eye opening, and if the VAS score was greater than 4, fentanyl 1 microgram per kg was administered, and patients were instructed to use PCA after extubation. And PCA device with the drug fentanyl was set like with a bolus dose of 15 micrograms with a lockout interval of 10 minutes and a maximum 4-hour limit of 240 micrograms. And rescue analgesia is given with 1 mg per kg of tramadol intravenously if the maximum 4-hour limit of fentanyl was reached and the patient continued to have experienced pain. And the study concluded at first 24 hours on postoperative period, and patients who required emergency reactivation during the study period or remained on mechanical ventilator beyond 12 hours or died during the study period were excluded from the analysis. And sample size was calculated from based on previous study with 80% power, and appropriate statistical stats were used, and a p-value less than 0.05 was considered significant. This is the consort diagram. Total 130 patients were assessed for eligibility, and 22 patients were excluded for various regions, and 36 in each group. Total 96 patients were divided into three groups. And in group PD, 2 patients, and group PL, 2 patients, and group PS, 1 patients were excluded from analysis for various reasons. Totally 34 in PD and 34 in PL and 35 in PS group were analyzed. Coming to the results, the demographic variables and the diagnosis of during surgery were comparable across the 3 groups. Coming to the postoperative analgesic requirements, the mean postoperative fentanyl requirements were ranging from 370 micrograms to 411 micrograms. They didn't show any significant difference, although the studied drug groups have less requirement of fentanyl. Coming to the intraoperative fentanyl requirements, that is from induction of anesthesia till the beginning of surgery, it has significantly less in dexmedetomidine group. In fact, only one dose of fentanyl was required. Duration of mechanical ventilation was comparable, ranging from the 324 minutes to 336 minutes. There was no statistical significant difference. And VAS scores were at different time points were comparable across the group.
So you
and
have
heart,
30 more seconds.
Yes. Heart rate was comparable. Mean arterial pressure showed significantly less in PD group. And other parameters like duration of surgery, total duration of tramadol, other parameters were comparable across. Coming to the discussion, we found lesser fentanyl consumption group PD and PL, indicating the effectiveness of both study drugs. And our findings were in agreement with the earlier studies. And significantly less intraoperative fentanyl requirement in PD group in our study supports the findings from previous studies. And the preoperative use of dexmedetomidine reduces the opioid consumption. Our results, the shorter duration of perioperative postoperative mechanical ventilation were in agreement with the previous studies. Although our findings didn't reach statistical significance, they reflect a consistent trend supporting the dexmedetomidine's role in enhancing recovery. Significantly less mean arterial pressure intraoperatively in group PD could possibly explain the less significantly requirement of intraoperative fentanyl in that group.
So
we had some limitation. Yes, we have some limitation, small sample size. We have used the same dose during the CPB, and certain other limitations we have. But to conclude, in combination with paracetamol and intercostal block, both dexmedetomidine and lignocaine have comparable postoperative analgesic requirements in patients undergoing cardiac surgery. Intraoperative fentanyl requirements are significantly less in dexmedetomidine group. No statistical significant difference in terms of duration of postoperative mechanical ventilation and VAS scores. Heart rate was comparable at all time points, while mean arterial pressure was significantly less in group dexmedetomidine group. These are my references. Thank you.
Okay. Thank you. I request our chairpersons to please give their opinion.
Thank you, Dr. B. Padala, for your presentation. And you can stop sharing your screen. And I congratulate you on your good study done in patients suffering from post-operative pain undergoing cardiac surgery.
Yes.
They were all patients with the valve or CABG, or all profile you took?
Sir, we excluded CABG, revascularization procedure, sir, to maintain uniformity. In our center, revascularization was done off-home, sir. So to maintain uniformity, we included patients during cardiopulmonary.
I got my answer. So in addition to your intercostal block, what are the other alternatives we can use?
Regional anesthetics like erector spinae block, paravertebral blocks, or epidural even can be used, sir. But on the background of anticoagulation with respect to the cardiac surgeries, they are less well established.
Something near to the sternum, bilateral side. Pectoral interfacial pain blocks.
Yes, sir. Please have blocks. Yes, sir. Can be given.
God bless you. Thank you. Over to Dr. Kalsap.
How did you appreciate the demand of the fentanyl from the start of the surgery to the incision? How did you?
Yes, sir.
How did you monitor it?
Yes, sir. Following induction, we gave paracetamol and intercostal block, sir. And any heart rate and mean arterial pressure more than 20% from the baseline, we assumed due to pain, sir. And we gave 1 microgram per kg bolus dose of fentanyl till the patient went into CPP, sir. And we measured the number of boluses of fentanyl required in each group, sir. That was less in dexmedetomidine group, sir. In fact, out of 33 patients, only one patient required 1 microgram per kg, 1 bolus dose of fentanyl, sir, in dexmedetomidine groups.
Thank you.
Thank you.
Thank you, sir. Thank you.
Dr. Vishal?
In how many, yes, sir. Good evening, sir.
Good evening.
Yes, sir.
At what levels did you give the intercostal block?
Sir, intercostal block was given bilaterally from 2nd to 6th intercostal space, sir. 5 spaces on either side, sir. Total constituting 10 spaces, sir.
And how much volume did you give in each space?
Each space 4 ml, sir. This is a described technique in the earlier studies, sir.
Right. Thank you very much.
Thanks.
Okay, sir. Shall we proceed, sir?
Yes, please.
I request our next participant, Dr. Poonam, to please share her presentation.
Hello, good evening, ma'am. I'm sharing my presentation.
Okay.
Is it visible, ma'am?
Yeah, all right.
Good evening, all. Today, I want to discuss a very alarming topic which we are dealing on a daily basis, carbon footprints in healthcare. So what are carbon footprints? Total greenhouse gas emissions by any means as carbon dioxide equivalents, measure of the global warming potential. So what is global warming? It is the long-term warming of the Earth's surface temperature. Prior to industrial era, there were natural events which had slow solar cycle variations. But since 1800 human intervention, it has accelerated, leading to the Earth temperature 1.1 degrees centigrade warmer than the late 1800s. So why should we be discussing it? It is environmental change is very real. It is affecting our existence and we are causing it and we can prevent it. So these are the photographs of our own nation depicting poor air quality index. And as per UNDP data, climate change is much deadlier than cancer in some places. So what is the impact on public health? It causes air pollution, changes in vector ecology, increased allergens, water quality impacts, food supply, environmental degradation, extremes of heat and severe weather, leading to asthma, malaria-related illnesses, respiratory allergies, cholera, malnutrition, forced migration, mental health impacts, heat-related illnesses, and injuries. So multiple organizations are working to mitigate these effects. There is this UN Environment Program, World Meteorological Organization, and Intergovernmental Panel on Climate Change. Various conference of parties have been held since 1995 to present. In 1997, Kyoto Protocol with the aim of reduction of greenhouse gas. Then now in 2025 in November, COP30 is being planned in Brazil with a target of limit global warming less than 1.5 degrees centigrade. So what is the greenhouse effect? With the sun's short waves, they heat the ground. Warm air rises and heats the greenhouse. Infrared rays radiating from the ground and cannot pass through the glass, but the longer wavelengths radiate to the atmosphere. So is it really bad? Without the greenhouse effect, average temperature would have been about minus 18 degrees centigrade rather than present average of 15 degrees centigrade. So we would have been into the ice age. So why the descent? Because of the human activities such as burning fossil fuels and deforestation, it has caused a jump in the concentration of greenhouse gases in the atmosphere, resulting in the extra trapped heat and higher global temperatures. Global warming potential, the main focus in carbon, it depends both on the warming potential and relative abundance. So here, nitrous oxide, it has abundance of 6%, but the potential of 300, which is a measure of how much heat each gas traps in the atmosphere relative to carbon dioxide. Fluorinated gases, they have abundance of 2% with a potential of 1000 to 10,000. So this is a pie diagram showing share of world's carbon footprint. With China contribution of 27.2%, 15.6% from USA, and India contributing 6.3%. We have the various methods for assessment of carbon footprints using life cycle assessment method. It starts from the product design, resources, production, packaging, transportation, administration or distribution, usage, waste disposal, and lastly, recycling. This is also the cradle to grave approach, starting from the raw material acquisition till the end of life. So environmental emissions from perioperative services. It starts from the consumable products like medical devices and pharmaceuticals, inhalational anesthetics, and facility energy consumption. Coming to sevoflurane, it has global warming potential 20 year of 349, while isoflurane has 1401 and desflurane has very large 3714. If we add nitrous oxide to our mixture with the sevoflurane, this global warming potential for 20 years jumps from 6,980 to 40,940 for sevoflurane, and from 15,000 without nitrous oxide to 44,000 with nitrous oxide with isoflurane. Coming to kilometers driven, in terms of common anesthetic gases, carbon dioxide equivalent can be expressed for 1 mega. Sevoflurane contributes to 6.5 kilometers, isoflurane 14 kilometers, nitrous oxide 95 kilometers, and desflurane contributing to the largest of 320 kilometers driven. Are we really contributing that much to the damage? It is a volatile anesthetic is 0.01 to 0.1% of the total global carbon dioxide equivalent emissions. We are contributing 5% of the hospital greenhouse gases. As per the American Society of Anesthesiologists, new guidance have been published regarding reduction of the carbon footprint to avoid inhalational anesthetics with high climate impacts, desflurane and nitrous oxide, lowest possible fresh gas flow use, and regional anesthesia and intravenous anesthesia to be preferred. New method of destroying waste anesthetic gases using gas photochemistry has also been tried with efficient and cost effectiveness in both sevoflurane and desflurane, but additional modifications required for the removal of the nitrous oxide. Other contributors to carbon footprint, which are shown in the table from the data of 2017 and 18, they also contribute to the emissions like single-use disposable devices, packaging and containers for fluid, and drugs responsible for emissions. Other strategies for mitigation include managing supplies, equipment, medications, reducing surgical facility emissions, and perioperative strategies like telehealth, ERAS protocol, and limit the perioperative testing. This is a study of total knee replacement, which highlighted that spinal anesthesia can also contribute to equivalent carbon dioxide emissions as the general anesthesia because of the higher contribution of the electricity for warmer, scavenging, and anesthesia machine, and electricity for cleaning reusables, plastics, and gowns. So we must also consider these facts while considering type of anesthesia to be given to the patients. Innovations towards achieving environmentally sustainable operating theaters have been advised in a systematic review that highlights perioperative environments use 3 to 6 times more energy than the hospital. Paper recycling bin can lead to the 50 to 67% recycling rate. Reusable items can lead to 70% reduction in waste generation. Alcohol scrub solutions over hand washing. Dispensing propofol in 20 ml bottles. Then we should follow the circular healthcare economy from redesign, reduce, retain, repair, repurpose, and finally recycle. I would also like to highlight the role of digitization as published in Irish Medical Journal. In a single day, if the server is supplying one tertiary hospital, two small general hospitals, and the community and primary care services, if they are sending 28,800 emails, the per email generation of carbon dioxide equivalent is 4 gram, then it is equivalent of driving over 1.15 lakh kilometers. So to achieve a sustainable net zero healthcare service, every gram of carbon dioxide equivalent, every click and every email matters. But emails are just one example. Thank you. We do not inherit the earth from our ancestors. We borrow it from our children.
Thank you very much. I request our chairpersons to please share their opinion.
Thank you, Dr. Poonam,
Thank you so much.
for your nice insights into the very critical issue of carbon footprints.
Yes, sir.
I am a pain physician. What is your advice for me? How I can contribute to decreasing these footprints?
So we should go for the tele-PACs. Like if it is not required for the patients to come to us for follow-up, then we can advise telephonically also. And then we should use for drugs, we should use pre-filled syringes. They must be high costly on the initial side, but for recycling purpose, they would decrease the overall cost effectiveness.
Okay. So, okay, I understand that follow-up, we can use telemedicine.
Yes, sir.
But for the primary workup, patient has to be
Yes,
examined
sir.
to know the pain generators. But I take these 2 points, that use of telemedicine and use of pre-filled syringes.
Yes, sir.
Okay, God bless you.
Thank you.
Dr. Bhaskar?
I request Dr. Tej K. Kaul sir to
Kaul
please
sir?
give his opinion.
Thank you. Thank you, Dr. Poonam.
Thank you, sir.
The topic of the day is the carbon footprints. Nice presentation.
Thank you so much, sir.
But I would like to know, where from did you get these percentages? You haven't mentioned anything about the source of your this, how much is the production by OTs from the automobiles and from other things. What is the source? Why
Sir,
from have you got this? You
sir,
haven't mentioned anything about it.
yes, sir, I missed that. But it is, I searched
And
the literature.
number two, what about how much does the stopping the recycling, if you just have it, all disposables to be sterilized at home by ethylene oxide or other methods, so that the recycling, how much is that percentage? How much can that be reduced? And what are the effects of that?
Sir, we can prevent the recycling because overall it starts from the production. The more cost effectiveness, more costly it is if we start from the production start. It takes more amount, but recycling does not account for that much cost to be costly. So we can use other methods.
We are not concerned about the cost as of now. We are concerned about the carbon footprint, their
Yes, sir.
pollution. How much will be that percentage if we stop recycling and start sterilizing them at in-house?
So sterilization,
You get my point?
yes, sir. Sterilization would amount for much higher carbon footprints as compared to the disinfection and other methods of cleaning and recycling things.
Have you? What is uh, what steps have you taken at your place of work for reducing the carbon footprints?
Sir,
Anyone?
yes, sir. Minimizing the number of syringes that we regularly use in the OT. And in OT, unnecessary use of the machine should be stopped. Unnecessary use of oxygen, everything we should take care, very vigilant.
How much have you? These are the general methods.
Yes,
How
sir.
much have you implemented? How much have you been able to implement it at your place?
So, like in case of monitoring, like during normal GA cases, if we are not using inhalational agents during the induction, also stopping the inhalational agents, and during emergence also stopping the inhalational agents, reducing the flow rates, that can prevent the inhalational agent.
Thank you.
Doctor, how does one email add on to the carbon footprints?
Sir, email, it leads on, as such, we are using the internet, and that is a electricity source of electricity. So we are using all of these things. For electricity, we require energy production, and that generate the carbon footprints.
So you mentioned that 28,000 emails produce 4 kilograms of carbon footprints.
Yes, sir.
So when 28,000 emails, 4 kilogram carbon footprints.
Yes, sir.
Okay. And second question is that which gas causes maximum ozone depletion?
Which gas, sir?
Anesthetic.
Sir, desflurane.
So that causes greenhouse effect. I'm talking about ozone depletion. Is it same?
Yes, sir. As per my search, it was same.
Thank you very much, ma'am.
Thank you, sir.
Thank you, sir. I would like to invite our next participant, Dr. Tanigai, to please share his presentation. Dr. Tanigai?
Yes, ma'am. Is it visible, ma'am?
Yeah, your presentation is not visible.
Right now, ma'am?
No.
What issue are you facing, Dr. Tanigai?
Ma'am, I'm opening screen, documents, share. Okay. Oh, I have not. Okay. No, ma'am.
No.
No.
You open
No,
your
ma'am.
presentation first in the background and then start screen share. We did a test run, right? You were able
Yeah,
to.
Yes, ma'am.
Yeah.
No, ma'am. No, ma'am.
No.
No. Did you click on the share button?
Yes, ma'am.
After that, you keep your presentation open first.
Yeah, it's open, ma'am, in my computer.
Just click on the share button and you can see a screen. Just click on your presentation slide, that's all. And then click share. In the screens.
I'm sharing. Again, sharing. One second.
It's okay, Dr. Tanigai. We can figure it out. We can have Dr.
Okay.
Jain first. That's all right.
Okay.
Don't worry.
Sorry.
Don't worry about
Okay.
it.
Okay.
Dr. Jain, are you ready?
Dr. Jain?
Yes, ma'am. Yeah, I'm ready.
Right. Please share your screen. I made you the co-host.
This is number 4. This is number 4 participant.
Right, sir.
Yes, sir.
Okay.
Is it visible, ma'am?
No, your slides are not visible.
Now is it visible, ma'am?
Yeah, somewhat. You can go
Yes,
ahead.
ma'am.
Yes.
Good evening, everyone. I'm Dr. Jan Rai, and today my topic is lessons from behind the mask, applying anesthesia to life. So before every case, I take a deep breath. The single breath is more than a habit, and it's a reset. As anesthesiologists, we live at the intersection of control and uncertainty. We hold someone's life in balance between awareness and oblivion, pain and peace. But somewhere along the way, I realized the lessons we practice in the operating theater are also the very principle that helps us navigate the life outside it. Because Anesthesiology is more than drugs and machines, it's a philosophy. And every case, every crisis teaches us the lessons which is applicable to the life. So before induction, we ready ourselves, we oxygenate, anticipate the complications, and prepare for the worst. Life follows the same rule. It favors those who prepare not out of fear, but out of awareness. Whether it's a new role, relationship, or the challenges, the principle remains the same. Plan thoroughly, stay adaptable, and always keep a backup. Because in anesthesia, as well as in life, hope alone is not a strategy. One of the humbling moments comes when a patient comes to you and he was very anxious and trembling before induction, looks at you and says, "Doctor, I trust you." That simple line carries immense weight. It's a complete surrender of control, fear, awareness. And in that moment, what we owe them in return is our calmness, our skill, and compassion. In the life as well, trust isn't earned through the words, but through the presence. By being there, staying steady, and standing by our word. We build trust just like we maintain oxygenation by being consistent, gentle, and vigilant. Anesthesia is a balance of extremes we all know. If it is too little, awareness will be there, and if it is too much, the body pays the price, and ultimately physiology suffers. We titrate it very carefully as well as consciously. Doesn't like the same between the ambition and contentment, speaking and listening, holding on and letting go. We are always titrating like our anesthesia. Anesthesia teaches us the importance of balance, patience, and compassion in life also. So every anesthesiologist has faced that critical moment. You all can appreciate that. The monitor starts screaming, oxygen saturation plunges, and the heart rate surges, and the entire room tightens with the tension. In those seconds, instinct meets training. Amid the chaos, we don't panic, we pause the breath and assess, because in anesthesia, clarity comes not from the speed, but from control. In those moments, the training kicks in, like to check the airway, breathing, and circulation, identify the root cause, and correct it. But ultimately, don't panic. What a profound life skill that is. The ability to pause before reacting, to understand before judging, and bring the calmness before taking the charges. It's the same principle that keeps us in the operating room and in life. Life crises may not flash or sound alarms, yet they call for the same disciplines like stay calm, take a deep breath, assess the situation, respond accordingly, but ultimately don't panic. Anesthesia may seem like a solitary craft, but no procedure is ever truly done alone. Like it's a symphony of teamwork. The surgeon's precision, the nurse's instinct, and the technician's preparedness. Each contribution is vital. In the life as well, we thrive when we work together. True leadership isn't measured by how loud we speak, but by how clearly we see, how deeply we listen, and how willingly we let others take the spotlight. In the operating room as well as in life, we all know that ego is the most and it clouds judgment, dulls the awareness, and endangers the harmony. Keep the ego outside, whether you are stepping into the OT or facing the life. No matter through the preparation or how refined the skill, not every case unfolds as expected. There are moments when, despite every right decision and every careful step, the outcome slips beyond our control. Anesthesia teaches us acceptance, not the coldness of indifference, but the quiet grace of understanding our limits. And in the end, it all comes back to the breath. The breath. Every journey in anesthesia begins and ends with it. The first breath after the intubation and the last breath before extubation. And in between them lies everything we do, everything we stand for, everything that defines our art. And maybe between the breaths of life lies entire purpose, like to be aware, to stay present, to remember that everything we control is temporary, everything we ignore still matters. So today, when I walk into the OT, I remind myself Be prepared, be calm, communicate with kindness, lead quietly, accept outcomes, and above all, just take a deep breath, because the deepest lesson anesthesia offers isn't about putting someone to sleep, it's about awakening ourselves to what truly matters, the beauty of balance, the strength in stillness, and the quiet, steady courage it takes to care in every patient and in every moment of life. So may your life be as smooth as your interface and your problem as reversible as your expectation. Thank you.
Thank you, Dr. Jain Roy, for that beautiful presentation about
Thank you
the
so much.
journey which we all do day in and day out throughout our career. Can I know
Thank
your
you, sir.
definition?
Sir, now I'm doing in trauma anesthesia, sir.
You are doing
PDCC in trauma anesthesia, sir.
how many years of post-graduation?
Sir, after 3 years of post-graduation and 2.5 years of SRship, I'm doing this PDCC. Sir.
So the importance of breaths vis-a-vis first year of postgraduate and now into your almost 6 years into anesthesia, do you find any difference in your feelings?
Yes, sir. First year, we just going to. I feel like this. In first year, I always feel like that. We just give the breath to the patient. But in now, I feel that before giving the breath to the patient, it's very essential to take a deep breath in ourselves, and then we can think rightly, we can think properly, and mostly we can manage all of those things, all of those any hazards or anything.
Okay. And in addition to taking a deep breaths, any other maneuvers you use in your day-to-day life in OT?
In OT, I just keep all of those things. Firstly, I am very that kind of person who are prepared before the OT, who are rightly prepared before the OT, because if any complications will be there, it's very difficult to find out any drugs or find out any the specific instruments. So if we prepare for those kind of situations, we are very easily found those things, and it comes so easily. It will solve so easily.
Right. So I echo your words that anesthesiologists have got their bodies made up of uh, iron and nerves made up of steel. So they should remain cool and calm even
Yes,
in
sir.
the crisis. And I'm reminded of my teacher, Professor Balveer Chavda. Whatsoever we had committed any mistake or we were in any difficult scenario, he used to come and quietly manage it. Thank you, Dr. Jain. Over to Dr.
Thank you so
Tejka
much,
Kaul
sir.
and Dr. Vishal, please.
Thank you. Thank you, Dr. Jan.
Thank you so much, sir.
Very nice idea. But what about the role of the pre-operative evaluation, pre-medication, and making the friends with the patient? The life becomes extremely easy and simple.
Yes, sir.
Probably the need of breathing under the mask in the OT would become much easier and healthier for a person like you.
Yes, sir.
That ought to have been given importance about the preoperative evaluation, pre-medication, and making a rapport with the patient just
Yes, sir.
outside the operation theater before entering the OT.
Yes,
Thank
sir.
you. The idea is good, but it
Thank you
needs
so much.
to be statistically to be evaluated and compared and thought that how which methods and which types are better than the others. Thank you.
Thank you so
Thank
much,
you.
sir.
Very wonderful presentation, Dr. Jain. It was so good to
Thank you so
hear
much.
your life anesthesia balance. I remember one word from my teacher, Dr. Naveen Malhotra, sir, that whenever there used to be some panic in OT, he used to say only one thing: "Trust me, Vishal, I'm here." And I used to get cool. I still, in many difficult situations, I remember those words and I get cool. Thank you very much.
Then he also
Thank you so
says
much,
one
sir.
very interesting thing, that to have faith on your professors, which I totally
Exactly.
love, by the
Yes.
way.
Yeah, that is what I meant to say actually.
Exactly. It was just awesome.
Nay,
Exactly.
I still say that word. Have faith in
Yeah.
your professors. We can also
Yeah.
manage cases. Okay, thank you, Dr. Jain.
Thank you so much, sir.
Dr.
That was
Naveen
great.
doesn't tell you only to have faith in him in the OT. He tells you to have faith in him outside the OT also for your
Yes,
general
sir.
upcoming.
Thank you, sir. Thank you, sir. Thank you very much.
Thank
Exactly.
Sir.
Thank
Thank you.
Thank you,
Over
sir.
to Dr. Neha.
Yes, sir. Thank you, sir. I invite Dr. Tanigai to please share his screen again. Dr.
Ma'am,
Tanigai,
yes, ma'am, I'm here. Ma'am, please make me co-host.
you are already co-host.
No, the host isn't allowing sharing for this meeting.
You are
Now,
already
yeah,
co-host.
now is.
Please
Okay.
try now.
Is it visible, ma'am?
Yeah,
Yes,
yeah.
yes.
Okay. Good evening, respected senior faculties and my dear colleagues. Sorry for the technical glitch. Before I start the presentation, let me have start. I'd like to start with a question. With that is there in everyone's mind. When the operation goes well, the surgeon is appreciated. Whereas if it goes wrong, usually the anesthetist is blamed. The core paradox is always happening. We always have wonder why. So let's talk about today the topic which is rarely opens openly. The why anesthetists are underpaid in under respect. So how to reclaim the value in identity in modern anesthesia. Myself, Dr. Tanigay, I'm a consultant pediatric cardiac anesthetist from Tirupati. So let's see, before solving the problem, we have to understand the issue. The paradox of anesthesia is that despite being central to the patient safety and the critical flow nature of our work, there are certain key challenges that directly impact our life daily, which is obviously lower pay, less visibility that is behind the curtain nature, and growing burnout among the anesthesia residents and in fact the consultants. Even in the top premier institute, you can see papers are coming out. But why does the perception persist? What gaps are existing? How can we reposition ourselves? So look at the root problem, why we undervalue. The unseen foundation shows that historical identity, what our roots as a technical specialty, not how others and even we ourselves view our role that is behind the curtain nature. And systemic undervaluation. The system rewards the procedures, not physiology, not prevention. Culturally, we often shy away from claiming the credits. Time-based, case-based reimbursement undervalues the cognitive, perioperative, and safety inputs. And look at our internal culture. We avoid advocacy. Mean by that, we avoid conflict, we accept undervaluation, we prioritize clinical efficiency over visibility. A non-collaborative mindset. What do you mean by non-collaborative mindset? Yes, we talk about among ourselves and to the surgeon inside the OT, we'll keep everyone calm, but we never go directly with the admin or the so-called inner circle of the hospital or any corporate setup. We generally go to, avoid that situation. And so-called perception trap, which is how the public and peers see us, the patients, putting patients to sleep, doctor. The true role is beyond that. And this is actually reflecting in our economic reality also. The revenue models favor proceduralists. Anesthesia time never been directly financial value. Look at the bar chart. The cardiologist, it's a rough payment. A cardiologist is getting higher paid comparative to anesthesia and general physician, whereas the general physician at least have excellent work-life balance, and cardiologists say good work-life balance. Anesthesia again comes under moderate, sometimes demanding work-life balance. The future threat is that will AI replace the anesthetist? If you see the automation of the task with the monitoring and dosing and prediction, it can be a threat. But what we have to understand, it cannot judge, it cannot empathy with the human touch, and crisis leadership cannot be done. So yes, AI is the new disruptor, but it can amplify us if we evolve from the operator to decision makers, from monitors to leader, a leader in patient optimization, physiology, and system safety. So how to reclaim our value? Respect doesn't come from titles. It comes from visibility, ownership. We must show the measurable impact-led initiatives speak our value. The anesthesiologist, not someone is always in the OR. It's beyond OR. Visibility, I'm pretty sure pre-op clinics, they are doing it everywhere. But what is lagging is still not up to the mark of post-op follow-up and data sharing. And leadership, if you look at the structured program like ERAS and quality leadership in ICU, quality improvement project, anesthetists are taking the leadership role. And advocacy, we have to educate our colleagues and publish the outcomes and mentor the trainees. So let's redefine our brand. What do you mean by that? Don't say that the patient one who puts in clip, and change the mindset of the other, even public, that the one who keeps the patient safe and alive. And use AI as a force multiplier. What do you mean by that? The role of AI is to make this empowerment. The goal is not to compete with the machine, it is to command them and use it. So these are the some certain things which I wanted to discuss under AI. AI is a broad terminology. Now we see phone also say everywhere AI. Actually, what is AI? It is comes under several terminology. The most core terminology which we use as under the medical description is machine learning algorithm, which is used in risk stratification and management. That's a core function. We can use it for the even anesthesiology, where risk prediction start from preoperative setting, and control like closed loop anesthesia systems, and integrate the if you look at the radiology deep learning algorithm and day-to-day life practice, I'm pretty sure everybody using chat GPT that comes under natural language processing algorithm. So look at, just integrate all from the preoperative to post-operative, integrate the perioperative flow. But yes, it has comes with ethical consideration and clinical oversight. The challenges are training the data bias, oversight of the clinician autonomy, and regulation like data safety boards. So these are the certain examples. I'm pretty sure this must have seen a MEC-sleepy algorithm, which control everything from top to bottom, like neuromuscular blockade and analgesia and sedation. And so there are certain other the companies comes up, the Edwards comes up with the hypertension prediction algorithm. It's used for mainly of cardiac surgery, high risk cases, using simply an arterial waveform analysis. And this is the game changer Cosmos. It is equivalent of butterfly IQ from the Apple. So you just have to take some view and it will guide you what to do, and it will calculate automatically everything. This is a GI-ASIS system, closed loop anesthesia delivery, unlike same like a CLAD system. And this is the Etiometry T3 platform. This aggregates the data, and it looks like a dashboard of Power BI and Tableau. So this will tell you the patient risk profile, algorithm, what next to do, and everything top to bottom. So this is something about using the AI for ourselves. And respect starts within self-perception. If we remain invisible, we will be replaceable. If we are indispensable, we have become invaluable. So let's stop underselling our worth and start shaping the future of perioperative medicine with AI as our ally, not our adversary. So the key takeaway is own your value, expand your role, let the change. This is just about income or prestige. It's about purpose, presence, and progress. The future of anesthesiology depends on how we see ourselves. Everybody knows in the hospital we are a good problem identifier, but what they tend to forget, we are a good problem solver also. So for that, we have to quantify the things in your hospital, put the values like I have reduced this much of length of stay to the protocol driven management, reduce the complication, increase the turnover time. So just put a quantification. The first step is to quantify ourselves. And then evolution of scope, they expand from the OR to the focus, research, data analytics, pain consults, and ICU care. And adapt the technology. This is the picture showing the adaptation of that AI or any technology in 2030. So for example, myself, I'm working in a tertiary care hospital. I would say it's moderate, sometimes demanding workplace. This is something 2 o'clock, we're putting an ECMO for the patient. But I also lead initiative in infection control program, and we do CAT meet and all this. We actively participate in all the meetings. And hospital gave the platform to go to the various national level. This is our RSACP, Bathinda, we are speaker and panelist and various workshop training. This all I learned it from the institute, and also learning from other perspective, like this is one of the mixed reality and virtual reality, where we can see how the heart looks and real time. And the happiness comes from not from income, it is also from the prestige, which is an own enjoy when you transform this much of life. These are the couple of photos from the heart transplant kids. And expanding the field, this is expanding the field from anesthesia to the perioperative. The future anesthetist is the perioperative physician, no more just anesthetist. So thank you. Let's keep redefining our profession, one safe patient, one bold step at a time. Thank you for patient listening.
You, Dr. Thanigai, for your presentation. We had talked about the problems. Solutions, I only saw three. One was quantify your work outside the OT, use of focus, perioperative pain physicians. Any other you can think of?
So, that's what, first we have to quantify our works, let increase the visibility within ourselves, within our hospital
I've listened
network.
those things I've listened.
Yeah.
But
So
anything else, if because see, I firmly believe you have to advertise yourself. No,
yes,
everybody, even
we
Amitabh,
always have the shy to take the credits. What
even
we
Amitabh Bachchan sells Navratan Tel Thanda Thanda Cool Cool. So I agree with that. But what are the other things?
so we can conduct outside meetings. I mean to say, apart from our national meetings, to public, private, like not within the academic community, to the go to the public and talk to what we have, to use the media public. In fact, our last presentation, one of the presenters showed how we put use our media, put the anesthesia into the public platform.
You see, I agree with you that we do World Anesthesia Day programs, which
Yes.
are majority we're celebrating amongst ourselves.
So that's
So,
what it has to go to the public.
so what are your inputs and thoughts about increasing the interaction of anesthesiologists with the public? One, you said that use media to address about the anesthesia. Other things which you can suggest?
We can conduct I mean for example CPR classes, so that will be useful to the community also, layman CPR.
That is being conducted regularly since I was born in anesthesia. Every World Anesthesia Day, CPR was classes were done for the attendants outside the OT or in the casualty or in the OPD complex. I'm talking of way back in 30 years. Something new and fresh. Because you talked about problems.
Yes, sir.
I'm interested in solutions.
Yes, sir, the solution, that's why I feel firmly believe that technology has to answer it, like.
Yeah, but technology is in front of us. We can afford it. The Research Society of Anesthesiology can afford it. But you suggest the ways and means how to implement the technology. What is your young mind speaking about that?
So we can put even nowadays people are using everywhere Instagram short reels of about how anesthesia. I pretty good. I'm seeing a lot of
Right.
people are coming
One
on that.
suggested use of media about advertising anesthesia. That is one aspect.
And
Whether
include the even within hospital, include the admin people where they don't consider as only till surgeons they will talk, so we include them in a meeting, or use them for branding, so they will also get very close to the anesthetist, inner circle of the.
that is the leadership skills and.
Yes,
Okay, I take it that you should teach the leadership skills in the post-graduation also, because I
yes.
have seen lots and lots, thousands of anesthesiologists into administration. I was in 200 committees and I have to tell them I won't leave my pain clinic OPD. I am first a clinician
First,
and then I'll come to the meeting. So please keep my meetings before 9 a.m. and after 5 p.m. So if you are active, the director or dean will pick you up. Okay.
yes.
So, but another thing which you have not talked about is, which is my favorite field, sit in the pain clinics, become a pain physician, have a direct interaction with the society, have a direct interaction with the patients and relatives, be self-sufficient, no dependency, no emergencies, work-life balance, lots of remuneration, right?
Definitely, sir. Definitely. So one of I think in anesthesia, pain physician is the only independent consultant where we can directly take the patient.
But that was missing in your presentation.
Actually, evolution of scope, I put it
I,
as a
I,
pain physician.
I missed reading the point pain physician. I may be
I,
wrong, but I missed
I
it.
agree. I agree. I agree.
Okay, over to Doctor. Congratulations, Doctor
Thank
Tejpi,
you.
sir, please.
Dr. Naveen has already discussed all the aspects of your talk, but I would add one thing more important in whatever all has been said
Sure.
and talked about it. We should not allow the specialty to be degraded by our own selves. We must always respect, love, and speak about it at every fora wherever we get a chance. Plus, the anesthesiologist taking part in the institutional administration, hospital administration, where the laws and rates and emoluments are to be finalized. There should be a confident and a very dynamic anesthesiologist in all the administrative capabilities, and for that, either the anesthetist should do a diploma or degree in hospital administration, or ensure that one is involved in all the such committees in the institution. Thank you very much. The idea is good, but it is a topic which needs to be discussed at all forums and with full stamina, vigor, and vitality. Thank you very much. Thank you.
Thank you, Dr. Tanige. Dr. Neha Mishra, we can call the next speaker.
Yes, sir. Yes, sir. I request Dr. Pooja Bihani to please share her presentation.
Yes. A very good evening, judges, dear colleagues, and team RSCP. And I'm delighted here to present my research work on efficacy of facial plane blocks for chronic pain in women.
We cannot see your screen, Dr. Pooja. We cannot see your screen.
One second. Is it visible now?
Yeah, make it full screen, please.
Is it full screen now?
No. Yeah, yes.
Okay. So, if we talk about chronic pain, it is often overlooked, but yes, a major concern and leading to morbidity in women undergoing breast cancer surgery. And if we talk about the prevalence and intensity of post-surgical pain, approximately half of the women develop post-surgical pain, and about 1 in 4 develop severe, moderate to severe post-surgical pain. So we can think about how important the concern is the post-surgical pain. But the risk factor are some of non-modifiable risk factor like young age, adjuvant chemoradiation therapy, nerve entrapment, as well as axillary lymph node dissection and all. But as a modifiable risk factor, and as being anesthesiologist, what we can work upon is to decrease the intensity of acute postoperative pain. And there is a strong linkage between the development, between the acute post-surgical pain leading to chronic pain development because of central sensitization and different mechanism has been proposed. So, prospect guideline, they consider the thoracic paravertebral block as a gold standard for acute pain management following breast cancer surgery, but leading to some of the disadvantages of the thoracic paravertebral block, like pleural injury and technical challenges, as well as central neuraxial spread. Certain facial pain block like PEX block, pectoral nerve block, erector spinae plane block, as well as thoracic interfacial plane block have been proposed and have shown good alternative, as well as by the prospect and the ERAS protocol as a good alternative to thoracic paravertebral block for managing post-surgical pain. Still, there is gap in about facial pain block and the incidence of the chronic pain. So our aim of this review was to synthesize current evidence on the role of facial plane block in reducing the incidence and severity of chronic pain. We consider the primary outcome variable at the chronic incidence of the chronic pain at both 3 and 6 months. We considered 3 months because ISP also consider chronic pain to be developed at 3 months post-surgery, and 6 months as a time period because other causes of acute inflammation are subsided by the 6 months of the time period. We also consider certain secondary outcomes which are more patient-centric, like severity of chronic pain, the 24-hour opioid consumption, incidence of acute pain, like the patients needing rescue analgesia, hospital length of stay, quality of recovery, and patient satisfaction at 24 hours. So before starting our study, the research, we registered at the Cochrane review and we followed PRISMA 2024 guidelines. Our research question was formulated as per the PICO, where the P is woman undergoing breast cancer surgery, I was in the patient receiving interfacial plane block, C, when the no comparator or IV analgesic we were used as a rescue analgesic, and outcome was the incidence of chronic pain. So all the database, standard database like PubMed, Embase, Google Scholar were searched till 31st July 2025. And independent screening was done by 4 authors, and full text reviews was done, and any conflict was there, then it was resolved by senior most authors. So as per the inclusion criteria, we selected only randomized controlled trials so that we can put on more concrete evidence on the facial pain blocks. Any studies like non-RCTs, abstract, review, case report, retrospective, and observational study were excluded. Even we excluded those studies where there was no comparator arm. We extracted data from those studies regarding study design, block type, which kind of block was administered, and timing of administration, either pre-surgery or post-surgery, what kind of local anesthetic or any adjuvant were used or not, and the pain outcome and pain scale were used. Cochrane risk of bias tool was used for critical appraisal of the study, and for certainty of evidence, we use grade approach. Regarding the statistical analysis, we use SPSS 30.0 and random effect model were used. From the all standard databases, we selected around 1100 studies, and after duplicate removals, 991 records were screened. And from that, after exclusion of observational and retrospective studies, as per the inclusion criteria, total of 15 studies were included in final review for this facial pain block. And as we can see, most of the studies were of the less risk of bias, and only 3 studies were having high risk of bias due to selection of the reported results. Coming to the results of this review, the first is the chronic pain at 3 months. We can see all the facial pain block in overall decrease the incidence of chronic pain with the log risk ratio of 0.43, with the confidence interval of 0.27 and 0.59, with the p-value less than 0.001. With the moderate heterogeneity of 46%, because we considered heterogeneity more than 50% as the severe heterogeneity. And if we grouped it in the subgroup analysis, we found the ESP block, the erector spiny plane block, was only effective in decreasing the incidence of chronic pain, while the PAX and SAP block was found not statistically non-significant in decreasing the incidence of chronic pain at 3 months. However, in the meta-regression analysis, none of the block was found to be statistically significant in decreasing the incidence of chronic pain. While at 6 months, again, all the facial pain block have shown to decrease the incidence of chronic pain at 6 months with the log risk ratio of 0.32, considering of the relative risk reduction of 1.5 times. At 6 months, ESP as well as SAP block was found to be effective, while PEX block was also not found to be effective even at 6 months. Only one study evaluated pain at 12 months as well. Regarding acute pain, patient needing rescue analgesia as well as 24-hour opioid consumption was less in the facial pain block compared to the control arm. Regarding certainty of evidence, we are providing the moderate quality of evidence because all of the studies were RCTs as well as risk of bias was not serious, and because of imprecision, because of more heterogeneity, we are degrading our evidence. So moderate evidence we are supporting for facial pain block for decreasing the chronic pain at 3 months as well as 6 months. So ESP block was found to be effective at 3 months, while ESP and SAB block both were beneficial at 6 months. Regarding thoracic paravertebral block, as we have discussed, it was not found to be beneficial in the previous review. While considering other facial plane block and regional anesthetic technique, a recent network meta-analysis published in this year only and found to be, they are also saying the facial plane block are effective in decreasing the incidence of chronic pain. However, in that review, only 3 studies were included and chronic pain was not primary outcome variable. Considering certain limitation of this review, because the included study, there were certain methodological limitations like the type of block, the type of local anesthetic and dose concentration used, adjuvant used or not, the catheter were used or not, and timing of block intervention was different in different studies. So we are not very certain, and it is also leading to heterogeneity in our the outcome of our study. And diverse pain scales were used like VAS score, NRS. Neuropathic pain was used only in few of the studies, included studies. And chronic pain was, as an endpoint, was used in very few studies. So we are not sure whether, because most of the study, the acute pain is the primary outcome variable and chronic pain is a secondary outcome variable. So the studies were underpowered to tell whether the facial pain block is effective in reducing chronic pain or not. And over the time period, there is a risk of attrition as well as performance bias is also there in the included trials. So in future, we need certain high quality multicentric studies where the chronic pain is used as a primary objective measure, can tell the better tell whether facial pain block decreases the incidence of chronic pain in women following breast cancer surgeries. Thank you so much.
Thank you, Dr. Pooja, for that nice presentation on chronic post-surgical pain, especially pertaining to the patients with the breast cancer surgeries. In addition to the breast cancer surgery, what are the surgeries, apart from the thoracic surgeries, where you find more incidence of chronic post-surgical pain?
One is all the thoracic surgeries, especially VAT surgery. Yeah, they are the leading thoracotomy, thoracic surgery. Even hysterectomy surgery is also having a high incidence of acute pain, and it has been shown that 2/3 of the patient undergoing hysterectomy, open abdominal hysterectomy, has acute post-surgical pain. And in that also, chronic various abdominal truncal block have shown to decrease the incidence of chronic pain after hysterectomy surgery, open abdominal hysterectomy.
One is
Second,
thoracic surgery, hysterectomy, others?
Second is laparotomy for cancer surgeries, specifically major cancer surgery, laparotomy. There's again shown to be increase in scope of chronic pain post-surgery. And amputation, yes, phantom limb pain, these are again a very high risk population for the chronic pain.
What is the most important cause of development of chronic post-surgical pain?
So, certain are non-modifiable risk factor. I'm not talking about modifiable risk factor is the acute post-surgical pain.
It is the single most important factor.
Yes.
If you do not treat the acute pain properly,
yes,
you are going to land up in chronic post-surgical pain. And as you rightly defined it, it is going to occur after 3 to 6 months. Persistence of pain with no other identifiable causes, then only you tend to label it as chronic post-surgical pain. And as an anesthesiologist, we do not see the patient after 3 months.
Yes, sir.
That is the unfortunate part of it, because they will come to the pain clinics where the person who is connected to the anesthesia is not aware of that, or the patient may go to some other setup. So here lies in importance of having dedicated acute pain services.
Absolutely, sir.
Those of you who are working in OTs, my suggestion and advice is, should work to develop APS in your institutes.
Yes, sir.
Thank you, Dr. Pooja. Dr. Kaul, please.
Thank you, Jidana. Thank you.
Thank you, Dr. Pooja. We move on to the next speaker now.
Okay, sir. Thank you so much.
Okay, sir. I request Dr. Prerna Agarwal to please share her screen.
A very good evening to everyone.
Any problem, Dr. Prerna? Dr. Prerna? Yes.
Is it visible now?
It's visible, but we can't hear you. Yeah, it's visible. Please go back to the first slide. Yeah.
Ma'am, is it visible now?
Yeah, it's very much visible.
Good evening, everyone. Today my topic is...
We can't hear you. Dr. Prerna?
Yes, ma'am.
Yeah, please start, Dr. Prerna. Just be a little louder.
Yes, ma'am. A very good evening to everyone. Today my topic is apology, whether it's an emotion or a logic. Ma'am, I'm doing stuff now.
You can click on the play button.
It's not audible. Not audible.
Right. So, uh,
Dr. Prerna, what is the problem?
Ma'am, it's not shown to me. Like, I can't change the slides.
can
You
you
have
to play the slideshow?
you have to just click the arrow button.
Yeah. On the
And
right.
next, on the right hand side, you can see in your keyboard, on your keyboard,
Yes,
up,
ma'am.
down, and left and right arrows are
Yes,
there,
yes,
na?
yes,
Just
ma'am.
click that.
I'm clicking that only, ma'am. But
I think something is coming on her screen on the top.
I think
No.
we'll figure this out with Dr. Prerna. In the meanwhile, we can have the next presentation.
Dr. Abhishek.
Yes, ma'am.
Dr. Abhishek Kumar, are you ready?
Yes, ma'am. I'm sharing.
Yes, okay.
Is it visible?
Your screen is not yet visible.
Is it visible now?
Yeah, make it full screen, please.
So full screen, is it?
Okay.
Okay. Can I start?
Yes, yes, please.
Okay. Good evening, everyone. Good evening, Chairman and my colleagues. So my topic is information overload in the digital age, the hidden impact on our minds. While Dr. Neha was giving me the topics, one of the category was social issues, and I think this is the social issue which we are facing every second. Now, I was inspired for this topic by two reasons. One was my favorite book, that is Brief History of Humankind by Yuval Noah Harari, which have led to the history of humankind. And the second thing is the thought that we are in the age, our youth, the age, we are the generation which have lived a life without technology or minimal technology. And we have seen the transition of technology and the data in last 25 to 30 years. And again, we are entering the age of artificial intelligence. So I'm going with the topic of information overload, or in what we are commonly now, the terminology is coming as information obesity. But information overload is not a new term. It was first coined around 1960 and popularized in a book, an American author, in where he talked about future in Future Shock. It is defined as a state where the volume, complexity, or contradictory nature of information exceeds an individual's capacity to process it effectively, leading to reduced decision quality, productivity loss, increased stress, and mental fatigue. I think we all are going through this stage where we are suffering for this due to extra data, extra information we get from the time we wake up till we sleep. And the most important component is the volume of data which we are receiving, or whether that the volume of data is of low relevance, and what is the quality of that information. So it was from a magazine which I took that the average office workers gets interrupted every 3 minutes by new information. I think this applies for us also. We touch our smartphone, I think every 30 seconds or 1 minute to see any notification or any new information or any new data. And in 90% of the time, those are useless. So what are the sources of data? I think this is an exhaustive list, but if we look into things, I have underlined some of the data sources which are important to us as an anesthesiologist and professional. We get it. Emails, every time promotion, updates, and important emails. Now we have to filter what are the important emails. Similarly, instant messaging apps, WhatsApp, phone calls, we receive many calls, spam calls, social media. Every 1 or 2 minutes, we want to see our feeds, software, dashboards, digital advertisement, the advertisement which even think that pops up due to algorithms, newer websites. Every day there are newer apps launched. now this is important, journals and research articles. Now we have flooded with journals and research articles, and it's again difficult to see which is the true information, what we can really use and what we can really help in developing ourselves and the patients. Online courses, daily webinars, conferences, hybrid classes, video platforms, storage. Again, so there are an n number of data sources. So why I'm talking and why should we worry about data obesity? Now this can be divided into as individual concerns which we are facing daily, as well as a societal, economic, cultural, and as of a human race. Individual concerns, cognitive fatigue leading to mental health issues. This is a very emerging issue in our generation. Increased stress and anxiety. Maybe it is one of the reasons that we are always getting new information, we are not able to process it. Decision fatigue affecting personal choices. Sleep disturbance, again, we have screen time before sleeping, reduced productivity and quality of life. And if I'm not wrong, everyone of our generation is facing this. About human race, societal fragmentations and reduced collective focus, spread of misinformation and fake news, which sometimes lead to many societal problems, cultural shifts and changing communication norms, public health burden due to mental health conditions, and slow progress on global issues due to decision paralysis. Let's assume now this slides I just want to focus, which we have forget a life without excessive information. I'm not saying that the data and information are wrong. The data, information, and technology has helped us in gaining many things, positive things. But what was the life without access information? And if we see our generation of our parents, teachers, senior teachers, we'll see that they were happy people. They were knowledgeable, happy, creative, and they shaped us what we are. Maybe this was due to they were more focused. So individual benefits were greater mental clarity, enhanced decision-making, reduced anxiety and stress levels, improved sleep, meaningful and social interaction. What are the societal benefits? Increased collective attention to important issues, lower risk of spreading misinformation and fake news, strong cultural identity, better overall public health, and more efficient innovation and problem solving. So I have just included as a professional anesthesiologist, what is the problem with our data overload? Overwhelming clinical data increases cognitive load. If we see, I think every day we have about thousands of new journals with new articles. We sometimes get confused, which should we read and how much those information are correct? What is the source of the information? What is the clinical applicability? Heightened stress, fatigue, and burnout. Along with our profession, it comes. Impaired situational awareness and decision making, delayed or erroneous clinical decision risking patient safety, increased administrative burden, communication failure. Again, lack of communication has become a very important problem, that is face-to-face communication. Need for improved information management skills. So some of the solutions which can be done to prevent this, I think in an upcoming epidemic is using, we know that AI has entered in our daily life. So we have to embrace it with open arm, but within a positive way. So first thing is like smart tools like AI. We should use AI to show only the most important information, which is important for us. Limit how much information you take in and focus on what really matters to us. Take regular breaks. We have heard it from like digital detox for last 20 years for improving our mental health. Make apps, websites, and devices which are easier to use with clear and simple design. And learn better way to organize and manage our information daily. This should be individualized like we individualize our clinical decisions. And work together using shared tools to avoid getting repeated or unnecessary information. Thank you.
Thank you for your presentation. And can you please stop sharing the screen?
Yes, sir.
And can you have your video on if you don't mind?
Yes, sir. Yes, sir. Yes, sir.
So I understand that this is one of the menace of excessive information. If we don't have information, that is an issue. If we have excessive information, that is an issue.
Yes, sir.
For the youngsters, the first year, second year, third year, who are glued to the mobile, what is the possible solution which you can suggest?
Yes, sir. I think the first thing is we go with the school. So it starts from the schooling, that is the digital education, and digital literacy is an upcoming thing which I think the
Abhishek,
Yes, sir.
I want to implement a policy of use or disuse of mobile phone in the OTs.
Yes, sir.
What is your take on that?
So I think in today's era,
Uh,
the use of mobile phone in OT should be done, but the decision, the postgraduates or the trainee should be trained how to use it for their own benefit, for their personal benefit, and for the patient benefit. Sometimes we need information instantaneously for a good clinical decision making. Maybe it
that
required a
can
few
be that can be if senior resident is there, he will take care of that. If you want to see anything, Google, or you want to use it as a camera, as a magnifying lens, to search for a newer thing, agreed.
Yes.
But I've gone through the both of the things. I want to, because you are a young. I am also young, but you are younger than me.
Yes.
Immediately everything is settled. Either
Yes,
you
sir.
are on Myntra or Flipkart, or you are talking to the courier boy, drop this courier in the OT, or you are on the Insta, or WhatsApp, and
Sir,
you are not studying.
sir, I think the use of phone inside OT should not be generalized or should not be promoted like in trainees, because this compromise with the knowledge as well as patient safety, which is I think most important thing if you are inside our OT. Use of unnecessary apps like Myntra, Flipkart, Facebook, social media,
So
the
suppose,
reduction of screen time of these apps.
suppose
Yes,
Abhishek,
yes,
I pass an order. First year, second year, third year will not use in the OT.
yes,
Please
sir.
guide me how to manage the withdrawal syndrome.
Sir, I think this is a more very difficult thing in today's generation. But again, sir, I'll insist that this should be come from the individual trainings that which we cannot force this, sir. If we force it, it can again backfire us with that we are forced against our independence.
We can
And
have a revolution like in the Nepal, so people, resident will say that we won't come to the OT without mobile phone.
so that is what I'm saying. This is a very important topic. That's why I chose this topic. This can be like
But
the next.
I see, my viewpoint is that I want to learn the solutions from the youngsters. Your
Yes, sir.
mind is bubbling with fresh ideas and a zeal, enthusiasm. So give me one idea how to overcome this menace. We know that this is a problem. We
Yes,
are
sir.
speaking about it. We have discussed about it. Tell me a practical solution.
Sir,
Yes, sir, ye kar do, this will be good.
Sir, I think in a non-academic way, we can just talk to our trainees and PGs at the end of a month or at the eviction to just share about their screen timings in what apps and what are the positive things those they have got from apps and what are the good things they have learned from smartphone. And we can reinforce that what are the good things they have learned from smartphone to do it
God bless you.
continuously.
Abhishek, we cannot open the screen of anybody,
So
and
screen time, screen
even,
time. Just
even of our own kids also. And there are multiple gadgets, one to show, one to, so nowadays, anyhow, I look forward to more inputs from your side, and your presentation was absolutely according to the current scenario, and you have try to catch hold of the bull's horn. It is difficult. The bull is making some movements, vigorous
yes, sir.
movements, and we have
Yes,
to overcome that. Thank you
yes.
very much. God bless you.
Thank you, sir.
Dr. Call, sir, anything from your side, please?
Thank you, Dr. Abhishek.
Thank you, sir.
A very good idea you have given. It is more than 2 decades back. I wrote an
Yes,
editorial in Journal of Anesthesiology, Clinical Pharmacology about mobile phones, bane or boon. Look for it.
yes, sir.
Journal
Sure,
of
sir.
RSACP editorial I have written more than, I don't remember the year, more than 2 decades back.
Sure, sir. I'll go through it.
But at that time, I never heard this word of information obesity.
Yes, sir.
This is a new thing which has come since then, and information obesity is really a matter of concern. You cannot. Information obesity is going to lead worse things: wastage of time, wastage of energy, wastage of resources. When such an information is available, one should look for only those information which are published primarily in the PubMed index journals or which have some relevance, which have significant authority, and not go for any publications which are Tom, Dick, and Henry starts writing here or there without any evidence. So everything
sir.
has to be evidence based, and one has to find ways and means to get rid of this uh, obesity, information obesity. And Dr. Naveen has rightly asked you to devise ways and means and tell us that how it can be done. And I would also like you to read my editorial in GeoACP. It is more than 2 decades back. Mobile phones, bane or boon.
Yes, sir.
Thank
Sure,
you.
sure.
Thank you.
Thank you.
And move to the next speaker, Dr. Neha.
Dr. Prerna, are you there?
Dr. Nitin, welcome. Good evening.
Good evening, sir. Good evening, everyone. I'll be taking forward from here. Dr. Prerna?
Yes, sir.
Yeah, please share your slide.
Yes, sir.
In case you have any problem, let me know. I have your slides. I can play them for you.
Sir, I'm unable to share because I am
Okay,
unable to.
I'll do that. I'll do that. You're audible now, so maybe you can
Switch on your video.
switch on the video. Can you see your slides now?
Yes,
Yeah,
sir.
great. So you are good to go. I'll keep playing the slides while you speak.
Okay, thank you, sir. Sorry for the inconvenience. A very pleasant good evening to everyone. I, Dr. Prerna Agarwal, first year anesthesia resident, wanted to talk about a very underrated word, apology, whether it's a emotion or a logic. I apologize or I am sorry. Are they same or they are different? In broad terms, they both are same, but in minor details, sorry refers to the feeling of sorrow, regret, or guilt, whereas apology, it is a regretful acknowledgement of any offense or any failure. Sorry is mostly an informal way in which like we say to our colleagues, our friends, but apology, it's a more formal way of saying sorry to our seniors and all. Next slide, please. A very bad history behind sorry. The word sorry was invented when the Australian society in late 18th century showed racism, and they used to take the children of lower socioeconomic status. They forcefully send them to civilization, separate them from their families, and they torture them mentally, physically, and sexually. Later, in 19th century, when they realized it's a big offense, they returned all the children to their homes and they said sorry. From then, on 26th May, the world celebrate World Sorry Day on 26th May. Next slide, please. Let's talk about people's mindset when they apologize. Some people apologize just to keep peace, but they actually don't mean it. Some people rarely apologize, whereas some people apologize when they think they're wrong, and few apologizes even when they're not wrong. Is there any language to say sorry? Yes, there are, like sorry, pardon, my bad, maaf perdona, and many more. Or just, I'm sorry says it all. Bruce Lee has well said, admitting mistakes are always forgivable if one has the courage to admit it. Apologizing, saying that I'm sorry, acceptance. The wise admits when they're wrong, whereas the fools will always try to prove a point. Ask. Asking forgiveness to heal the wounds of others. New idea, new mindset. New mindsets always results in new and better results. So these are the main effective way A's. These are the 5 A's of saying effective sorry. Do we have to say sorry for everything, or do we have to apologize for everything? Let's talk about it. Sorry, but not sorry. What does it mean? I'm sorry, but I'm not sorry for needing some time, saying no, giving myself priorities, giving my opinions, and having my beliefs, telling the truth, or having higher expectations. We all often make mistakes. But what is it which stops us from apologizing? Let's talk about it. So, as for me, there are few barriers of apology, like ego, lack of empathy, embarrassment, humility, guilt, thinking that apologizing is a sign of weakness or loss of power, our fear of repetition. Do we rank apology? Ranking doesn't mean which is like which sorry is better or which sorry is bad. It actually means to whom we are saying sorry. Sometimes saying sorry to a stranger doesn't affect us much, but saying sorry to our spouse or every close relatives affects us. We have certain thoughts in our mind. Why are we saying sorry? Why it's always us who says sorry? So this is what the ranking of apology means. Is every apology the same? Let's see. I'll narrate some sentences. Like, it's not that serious. You're overreacting. Fine, sorry. Are you happy now? Sorry if you were offended. But you know I'm right. Most people wouldn't get upset about this. I was just kidding, God. Can't you take a joke? This is how a non apology sounds. How to communicate sorry. It's not always saying I'm sorry is enough. Sometimes we just communicate apology by showing care, talking to people, listening to them, being there by their side, or being patient, giving them their own time. इरादा तो हमारा भी तुम्हें बुरा महसूस कराने का नहीं था, बस हमसे कभी कभी खता हो जाती है. Why we apologize? I apologize not because I'm wrong, but sometimes because I value our relationships more than my ego. These were the positive things which we saw about apology. Let's talk about a different section. Sometimes we say sorry, but we actually need to say something else. Like, I'm sorry, I'm crying. But we actually meant, thank you for listening and creating a safe place for me. Or, I'm sorry for talking too much. But we actually meant, I had so much fun exchanging ideas with you. Or, I am sorry, I am being needy. But we actually meant, thank you for being there for me. Being Indians, we have certain cultural beliefs also. Since childhood, we were taught touching something by mistake, by foot, or touching books by foot, we have to say sorry, or we just have to touch the book again and just say people sorry for your loss when someone is being hurt by us. scam alert. Does apology has a scam alert also? Yeah. Especially in our profession, we have the legal concern. Sometimes when a doctor says sorry, the attenders think he's not saying sorry because as in empathy. He's saying sorry because he or she has committed a mistake and that can sue us in the court. So yeah, that is a legal concern. I really thank my parents, teachers and colleagues for helping me and guiding me. In the last, I just want to say an apology is a lovely perfume. It can transform the clumsiest moment into a gracious gift. Thank you so much.
Thank you, Dr. Prerna, for a beautiful presentation on a different topic. And coming from a first year postgraduate and with the nice oratory skills, God bless you.
Thank you, sir.
And I acknowledge that you are saying you defended, I am sorry, and sorry, I am not sorry. So whenever a surgeon is bullying you, you should, how senior he or she may be, you should say, sorry, I'm not sorry. And whenever any of your seniors, maybe you think that he or she is not wrong, and but you are correct, then also there is no harm in saying sorry. And but I must appreciate your such maturity in talking about sorry and apology uh, and the importance of both of them. God bless you. Thank you very much.
Thank you so much, sir.
Dr. Kaul, sir.
Very nice idea, Dr. Prerna. Very nice. What is the specific relevance of your talk in anesthesia?
Yes, sir. We do have. Sometimes, as sir has said, we are being bullied by surgeons, and in that case, we sometimes just commit, ki, "Haan, it's our mistake," and we say sorry, and then they just blame everything on us. So I feel like in that situation, instead of saying sorry, we can be like, "I'm not sorry for this because it was not my fault. It was not the fault from my side." So, and secondly, sir, I feel that this is not only in our profession, but also being medicos when we are so much overburdened with the work. Uh, these small gestures make life very simple, sir. So, I feel in that way. That's why I took this topic.
So this means that one should be smart enough to say sorry but not feel sorry. To
No,
avoid
sir.
to avoid to avoid bad feelings and bad situations to happen. Is it like that?
Sir, in certain situations, we can do like to maintain our mental peace. What I feel, ki, it's okay. We can like
Will
end the
it will
matter
it
there just by saying sorry and satisfying others' ego.
in certain persons the mental peace may be more disturbed. One feels that why should I feel? But you have a good idea. You have it needs to an introspection and needs people to follow it. It has many more advantages than disadvantages. Thank you for a very nice presentation. Whether the need of the hour is like that to have such ideas coming from the young minds for peaceful coexistence,
Yes.
good. God bless you. Thank you.
Thank you, sir.
Thank you.
Vishal, sir, any?
Very nicely said, Dr. Prerna. And I must say that I would like to echo the words of Dr. Tej K. Kaul sir and Dr. Naveen sir that apologizing is important, but it should be done only keeping our dignity intact, and also when you actually feel that there is something wrong. Now, not to just to satisfy anyone's ego. Thank you very much.
Thank you, sir.
Thank you. We move on to the next presentation. I ask Dr. Iradavan to please share her slides.
Is my slides visible?
Yes, they are. You can make them full screen.
It's not full screen?
No.
It's in presenter view? Okay.
Yeah. No, it's fine. No, it's fine.
All right. So, good evening, everyone. And my topic is Bhagavad Gita in the practice of anesthesiology, ancient wisdom for modern medicine. Now, for those who don't know, that Lord Krishna narrated and peaced and calmed Arjuna, who faced his battlefield with perplexity and doubt whether he should continue this fight or no. Each anesthesiologist faces their own Kurukshetra. There are moments of pressure, uncertainty, and modern dilemma. Bhagavad Gita offers timeless guidance for these modern battles. So why I chose this topic? Because this book has stood the test of time. And I turn to Bhagavad Gita myself and find a verse which comforts me and that immediately brings a smile during the overwhelming sorrow. So there are certain personalities like Albert Einstein, J. Oppenheimer, the father of atomic bomb, Will Smith, the Hollywood actor, Sunita Williams, who's gone into space carrying her Bhagavad Gita, states that this book gives a perspective to life, and including Mahatma Gandhi. So people from different fields have utilized this book, and it still holds valid. Its teachings are valid. So to disclose, there are no religious or political agenda. The content is shared only to help solve difficult situations which we face in our lives with the guidance of this book's teachings. So what's Kurukshetra in anesthesia? Whether to proceed with a high-risk case, coping with limited resources like equipment failure, balancing personal versus professional duty, job satisfaction, at times overqualified for a job, not finding happiness in what you are doing. So every anesthesiologist faces Kurukshetra-like situations at one time or the other. I'm sure the seniors have already gone through this and have overcome all the situations, but the young minds at times need counseling. So another factor which our field faces is like stress. What I want to emphasize here is that article published in BJ in 2010 showed that women are more stressed than men in the same situation, and juniors are more stressed vis-a-vis the seniors. So if in the same situation, two people are having stress of different levels, do we really need to change the outside world? Why not bring about a change first within ourselves? So that's what Bhagavad Gita guides us with its principles. The Karma Yoga, work as worship. So you have the right to perform your duties, but not to the fruits thereof. So I just quote an example of a newly joined senior resident in our DM cardiac anesthesia. And he took a case in cath lab and the patient expired. And what I saw was that this person was literally in tears at the end of the case. And I was like wondering, why is it so? He's done his MD, he's gone through all this life death scenarios, but why so? And he shared his experience of the past week where he had seen more than 3 mortalities, and he was part of all of them. So what we want to share here is, if we continue to take the outcome of every particular action that we do as our own, the unhappiness or the emotional outbursts are yet to come. So always think that your karma is to do the right thing. You've done your right work with the skill you have and you had at that particular point. The outcome does not matter. Never consider yourself to be the cause of the results of your activities, because there are several other factors which come into play. Jnana Yoga, humility and continued learning. A wise person remains humble and always eager to learn. We always talk about that the learning at present day scenario is way different from what used to be earlier. The student and teacher relationship, what used to be earlier, is way different what it is now. Learning comes from within. When you have that humility to learn, the eagerness to learn, the quest to ask questions, and you have a master or a spiritual leader or a mentor in your field whom you look up to, whom you wish you want to be like them, and he guides you. So you stay open to new knowledge, techniques, and feedback. Sthit pragna, calm under pressure. So there are moments of crisis, difficult intubation, desaturation, cardiac arrest, we've all talked about this, which demands calmness. And Bhagavad Gita supports this to respond, but do not react. Leadership and dharma. So whatever actions great persons perform, others follow. So you lead by example, act by dharma. There are several articles which have been published on leadership, but why I feel that Bhagavad Gita is different because it talks about ethical leadership with dharma, which I'll be talking next. Bhakti yoga, devotion, and compassion. Even small acts like reassuring a nervous patient, holding a hand during induction, offered with love becomes divine. Compassion for patients, colleagues transforms the OR into a sacred care. So to summarize, the Gita principles which we apply daily in our anesthesia is karma, duty without attachment, jnana, lifelong learning and humility, vairagya, emotional balance, bhakti, compassion in your career, and dharma, ethical leadership. Whenever you're faced with queries about dualities, there are two ways on how you can answer that. So always choose the righteous path, what is the correct path and the correct way to perform a particular duty, and that will guide you to the true leadership later. So Bhagavad Gita does not take you away from work, it transforms your work into worship. So transformation awaits you on the other side of Bhagavad Gita. Thank you.
Thank you, Dr. Ida, for a pious presentation. And I also believe that करते हैं किशन कन्हैया नाम हमारा हो रहा है. So it's he who has given the teachings of the values of life. And yes, it's an honor for us to be in that area near Kurukshetra, where the sermons of Gita were preached to the Arjuna by the Almighty Shri Krishna. And you have very rightly explained about its importance in anesthesia. Beyond anesthesia, in other fields, have you any experience?
So I feel blessed that I have been in a very fortunate state throughout my life, family-wise and career-wise. It was the career step down recently which happened where I could apply this rule and I was forced to go and read Bhagavad Gita and find peace and solace after reading this.
Yeah, so there are numerous studies now coming up about the role of Gita in medical field, including pain medicine also.
Okay.
So, and definitely it is a multimodal approach, and one of them is the values and teachings of Bhagavad Gita. God bless you. Thank you very much. Dr. Tej Khalsa, Dr. Vishal.
Nice selection of the topic and nice presentation,
Thank you, sir.
which is all the more important in the present turmoil of the universe. Bhagavad Gita has tremendous relevance. It is not, you have basically talked about Bhagavad Gita and anesthesia, but I would say that it is applicable to all specialties of medicine, not only of medicine, of every other branches also.
Every aspect of life.
You have mentioned many names, but you have forgotten the most important person, Sarupali Radhakrishnan. He has translated Bhagavad Gita into English, and he writes in it, in the preface, that what is not found in Bhagavad Gita is not found anywhere.
Yeah.
So if you have to search for anything, any problem, solutions or anything, it comes there. I am quite happy and I am impressed that you had this idea and you talked about it. Lord Krishna bless you.
Thank you so
Thank
much.
you.
Thank you, sir.
Thank you. Thank you.
I recently read a book on Bhagavad Gita, ma'am, and it was by Paramhansa Yoganand, and it said that Pandavas and Kauravas, they all are inside you. Hundreds of ills are there inside you, and you have to conquer them by your 5 Pandavas. So it is a nice book, ma'am. Sometimes if you get time to read it, please go through it. Thank you very much. It was so wonderful presentation by you.
Dr.
Thank you.
Sood here.
Good evening, sir.
Hello. हाँ जी, excellent presentation, नीरा.
Thank you, sir.
कर्म किए जा, फल की इच्छा मत कर. पर ऐसा भी कर्म नहीं करना है कि हमारा फल जो है वो बिल्कुल ही हाथ से निकल जाए. That is what I think.
Yeah.
Thank you.
Thank you, sir.
So over to Dr. Nitin for the next.
Thank you, sir. Dr. Sangamitra, can we have your presentation, please?
Who's the next?
Yes, sir.
So Dr. Sangamitra, yeah, she's uploading a slide.
Good evening. Dr. Sangamitra here. I'm sharing with my slides.
Where is this? Is Dr. Sangamitra?
Number 11, sir.
Okay. Number 10. Number 10.
11.
So just now, Dr. Ira presented number 10. Now we have number
Ira
11.
presented. Actually, after this ought to have come Dr. Gauri, but it is okay. This is now Dr. Sangamitra. Huh?
Yes, sir.
Yes.
Yes, sir. Dr. Sangamitra here.
Okay. Okay.
Okay. May I proceed? I'm sharing my
please.
screen. Just a minute. Wait.
You just need to make it full screen. Yeah, you're
Is
good to
that
go.
okay?
Yeah, yes.
Okay. Well, good evening, respected faculties and everyone. I'm Dr. Sangamitra Sharma, and today I'll be talking about something that extends beyond patient care, our responsibility towards the planet itself. My topic is going green in the intensive care unit, something very simple yet has a powerful impact in our practice. Let's see how we can make the critical care more sustainable without compromising the quality of treatment. And thanks to Dr. Poonam, she has already mentioned about like the carbon footprints in our system. So she has already done half of my she has made my topic easy to understand for all. So yes, so let me proceed how we can incorporate this in our practice. So as we have a look in the ICU in our setup, it is one of the vital components of our hospital, right? It provides the specialized care, sophisticated monitoring, life-saving interventions, post-op care, end-of-life care, and also opportunities for training and research. But here comes the danger. Since it is one of the most energy-intensive and resource-consuming unit, it is associated with emission of greenhouse gases for about 10% of hospitals' total carbon footprint. The recent Lancet Countdown report on climate change highlighted the impact of healthcare sector on global emissions. The report indicates that the total emission footprint of the global health sector is about 5.2%. And as per the Healthcare Without Harm, the Indian health sector's contribution to the country's total emission is approximately 2%. So these are the various sources I have highlighted here. Including equipments, medical equipments like the monitors, the ventilators, the dialysis machines, the HVAC system, that is the heating, ventilation, and air conditioning system, the lighting, the 24/7 water supply, then the medical waste incinerations for like disposable gowns, gloves, syringes, packing materials, anesthetic gases, and also the pharmaceuticals. In addition, ICUs regularly entails the transport of patients, staff, medical supplies, which again contributes to emission of greenhouse gases. Out of all of these sources, the HVAC system contributes the highest for about 70 to 80% to the total greenhouse gases out of all the medical aspects, out of the entire healthcare system in ICU. So here comes the solution to this problem, the concept of green ICU. It is a multidisciplinary initiative to reduce the environmental footprint of intensive care units. Now, though there are various approaches, people already have become aware across the globe and in our country as well about this, and they have taken certain measures like under the NHM, the National Health Mission in India, the National Program on Climate Control Change and Human Health, and also in collaboration with the NCDC, that is the National Center for Disease Control, they have developed something called the Green and Climate Resilient Healthcare Facility Guidelines. Also, the Australia and the New Zealand Intensive Care Society, the NZICS, they have launched the Beginner's Guide to Green Teams very recently, last year. The European Society of Intensive Care Medicine, the ESIC, has already made up a paper, a ESICM green paper that outlines a structured approach to ICU to reduce the environmental impact, emphasizing energy efficiency and waste reduction and sustainable procurement. Okay, so now so since I've gone through multiple papers and I've also seen our practice. So here I have outlined 10 very, very easy steps, easy for us to remember, and also we can practice in our ICUs or in our setups. So very first, we have the energy efficiency, the improvising, the replacing the old lightings with LED, very simple, upgrading the HVAC system, and also using wherever natural light is feasible, like possible, use it. All these measures will drastically reduce the electricity use. And also not to forget, let's do an audit, like how last month what was the electricity bill, and this month how much, after taking all these measures, how much we have come up to, how much progress we have done. So these simple measures will definitely help. Second thing, the waste management. Of course, the biomedical waste management is also a part of, plays a major role in this. Apart from that, minimizing the single-use items, then opting out for reusable alternatives whenever possible. And also very important, many of the centers are implementing these days the digital record keeping system to minimize the paper waste in OPD setup, as well as we can also see ICU setup also we can bring it. Then hospital has almost every setup has 24 hours water supply, and we need it, of course, but we need to preserve it again. So installation of low flow faucets and water recycling systems will help in this. Then choosing of suppliers, okay, who use sustainable packaging or materials, and opting out for products with minimal packaging also, which are biodegradable as well as recyclable. And also let's prioritize local sourcing so that we can reduce the transport cost and the transportation emissions. Let's ensure precise dosing so that the we can minimize the medication wastage and also the risk of adverse effects, right? And we can conduct frequent checks to prevent overstocking and also reduce the risk of medications expiring. And if at all there are expired medications, there should be measures to dispose them to prevent contamination. Then technology cannot function without like alone, right? So we need the people. So education of the healthcare system, the staff, as well as the patient is very, very important here. Monitoring of the monitoring of the progress and also report and educating the entire team is also important here. Then also of going for innovation and technology, adopting of sustainable and like less energy consuming equipments is highly encouraged here. Last but not the least, engaging the community in this approach. So why does this matter? Because climate change is not a distant issue, it's a healthcare issue. By going green, we can improve air quality, lower operational costs, and even enhance patient recovery. So to conclude, this is our take home message. The green ICU vision, healing patients while healing the planet. With each action, whether switching off an unused monitor, rethinking procurement, or recycling medical waste, let's take a step towards a more sustainable healthcare system. Thank you.
Thank you, Dr. Sangamitra. Over to the chairpersons. Naveen sir, call sir.
Call sir, please.
Yes. The same, this is a repetition. Hello?
Yes, sir. Yes, sir.
Am I audible? This is a repetition of the earlier speaker. Who was it? Who was that speaker? What was his name?
Dr. Poonam had a similar topic.
Yes. What was his name?
So Dr. Poonam Godwal.
Okay, Poonam Godwal. Yes, yes. Nice topic. Things to remember. It has already been discussed. Fine. You can ask Dr. Vishal, Dr. Naveen something if they have to add anything. Thank you.
Thank you, sir.
It is good to see that more of youngsters are looking towards the sustainable, towards energy conservation, pollution, and all these things which are which actually make the place more livable. In NCR, we have an AQI of approximately 400. That itself makes it a gas chamber. So it's good to see youngsters speaking on these kind of topics apart from effect of these pollutants on healthcare system. It was very good to hear.
Thank you, sir.
Thank you.
Naveen, sir.
Sir is not.
All good, all good. Congratulations to Dr. Sangamitra.
Thank
And
you, sir.
yes, it is a very nice topic, and we have to do in our day-to-day anesthesia and ICU, and whichever field we are working, this is our responsibility now to care for the environment. God bless you. Thank you very much.
Thank you, sir.
So next we have Dr. Raghav Gupta. He's I think he's already started sharing his slides. Go ahead.
My slides are visible?
Yes, they're visible.
Yeah, okay. Good evening, respected faculty members. Myself, Dr. Raghav Gupta, and I'm working as an assistant professor in the Department of Onco-Anesthesia and Palliative Medicine at AIIMS, New Delhi. And today I'll be presenting on a very important topic, that is volatile agents versus total intravenous anesthesia in cancer surgery. What is the current evidence and future directions? Greetings from my institute, and I have no financial interest to disclose. So the scope of my presentation will include a brief introduction and why we should know about this topic. What is the neuroinflammatory response in oncological surgery? What is the mechanism of action in between these two anesthetic choices when it comes to cancer recurrence? What does the recent evidence tells us? The environmental impact, the ongoing studies, further by take-home message. So cancer, we all know, it is one of the greatest challenges to the healthcare system nowadays, both nationally and internationally. By 2050, it is expected that 35.3 million cancer cases will be there, and almost 18.5 million cancer deaths are estimated, which is a staggering 90% increase from the current estimate. So the most common modality of cancer death is not just from the primary tumor itself, but as a result of metastatic disease. We know that many cancer types, surgical resection is the primary mainstay of the treatment. But we must also remember that local regional tumor recurrence, it depends upon the fine balance between the metastatic potential of the tumor cells and the integrity of the host immune response. Therefore, this topic becomes imperative to scrutinize the long-term effects of surgical trauma, the physiological stress, and the immune suppression which the patient may undergo. And the important role as an anesthetist is the potential perioperative impact of our agents in reducing the inflammation, enhancing the immune function, and reducing the post-operative complications. The same has been highlighted in Journal of American Medical Association in 2024. So what happens in the perioperative period? We know that the cancer cells in the early stage, if they are promoted by the growth factors or angiogenesis, the tumor size will increase. And if there is a cell-mediated immunity is enhanced, then the size will decrease. So what happens during the perioperative period? There is the role of inflammation, immunosuppression, hypoxia, growth factors, and angiogenesis. And if there's a complete resection, then the tumor will be removed. But in many cases, the complete zero resection is not possible. And because of all these factors, there is always in the follow-up period chances of local recurrence and metastasis as well. So how the neuroinflammatory response works in the case of cancer surgeries? A neuroendocrine response leads to increase in the cortisol and the catecholamine levels, and the inflammatory response leads to immunosuppression. There is an increase in the tumor-associated neutrophils and regulatory T cells, which leads to release of IL-10 and tumor growth factor beta, and there is a decrease in the NK cell activity. All these factors combined together leads to cancer progression. So what is the role of TIVA and the inhalational anesthetic agents? They have diverging effects on cancer cells, the local and the systemic tissue microenvironment, and the host immunity. Theoretically, the greatest risk of cancer recurrence will exist when the cell growth and the metastatic potential combines together with the impaired cell-mediated immunity, which leads to tumor proliferating environment in the body. So inhalational anesthetics, they downregulate all the three things, that is the cancer cell, the normal cells, and the immune cells. But if you can see in this diagram, which was published in BMC Anesthesiology, that IV anesthetic agents are said to downregulate the cancer cells, but they upregulate the immunity by enhancing the immune cell function. So if I summarize the mechanism of action, with TIVA, the NK cell function is preserved, but there is decrease in the cytokines, decrease in the vascular endothelial growth factors, and increase in the hypoxia NDS factor, which is just the opposite with the volatile anesthetic agents. So what does the recent evidence tells us? In Korean Journal of Anesthesiology published in 2022, they compared the effects of TIVA on long-term oncological outcomes in patients undergoing the curative surgery for small cell lung cancer, but it was a retrospective study. And they found out that propofol-based TIVA was associated with better recurrence-free survival and overall survival in patients with stage 1 and 2 lung cancer surgeries. In British Journal of Anesthesia, they did an observational registry-based study in colorectal cancer patients. And in this propensity score matched study, the use of inhalational agents was associated with fewer post-op complications than use of TIVA, and there was better wound healing and surgical infections. In the case of Frontiers in Surgery published in 2023, they did study in lung cancer, breast cancer, and esophageal cancer, in which they found out that TIVA is preferable compared to inhalational agents for longer overall survival, but it wasn't associated with a better recurrence-free survival. Coming to inhalation surgery, they studied again propofol versus the inhalational agents, and it was a nationwide cohort long-term survival they studied, and they found no association between the type of the modality of anesthesia and the post-operative overall 1 year and 5 year survival. Coming to the another study, it was a meta-analysis. Anesthesia technique and cancer outcomes. This meta-analysis suggests that propofol-based agents may be associated with improved recurrence-free survival and overall survival. This is especially evident where major cancer surgeries were undertaken. And another very recently published trial in 2024 in Lancet, it is a systematic review and meta-analysis including 317 RCTs, 51,000 patients. There was no mortality difference, but TIVA definitely decreased the post-operative cognitive dysfunction. So there are a lot of studies which I went through, and almost I found 48 studies, and I've shown in this chart different amalgamation of different studies, but most of them are either retrospective cohort studies, observational studies, and very few are systematic reviews and meta-analysis. What is the environmental impact, which already been discussed in a lot of things, but I'll just like to emphasize that volatile agents, they lead to 3 to 5% of carbon emissions in the hospitals, but TIVA has almost near zero greenhouse emissions. Desflurane global warming potential is, you can see, it is almost 2,590 compared to the CO2. So there is a strong argument for sustainability adoption when it comes to environmental impact. So clinical summary table is that in the case of breast cancer, TIVA and the inhalational agent either can be preferred. In the colorectal cancer, TIVA has shown to be preferred agent because of reduced recurrence. And in the oral cancers, again, either of these agents can be utilized. When it comes to clinical outcomes overview, majority of the studies, as I mentioned, that there is no difference in the mortality. In the recurrence, it is lower with the TIVA in colorectal as well as lung cancer surgery. Recovery post-operatively is faster with TIVA, and environmentally, TIVA is said to be more superior and friendly. There are few RCTs which are ongoing and which will lay a foundation for a future perspective regarding this case. One is in the Melbourne Vapor-C trial, which is being comparing the inhalational agents with IV propofol and IV lidocaine to improve the disease-free survival. CANA trial evaluating the immune markers such as IL-10 and TGF-beta, which I mentioned initially, and CIVO-PRO trials, which see the recovery endpoints specifically in the gastrointestinal cancer surgery. So my take-home message is that oncology encompasses complex tumor biology. Beyond tumor-specific factors, there are a lot of perioperative elements such as inflammation, pain, stress, and surgical trauma that may influence the overall outcome. Given the millions of cancer surgeries which are happening nowadays, especially in India also, it is crucial to work towards maximizing the post-operative recovery and minimizing the cancer recurrence and metastasis. So as a perioperative physician, it is a role that how we can contribute in helping such kind of patients when they come for surgery. The existing body of research, as I mentioned, consists of majority of them are retrospective studies. Very small scale RCTs have been conducted with methodological limitations. It has been concluded in majority of the study that both the techniques are safe, but TIVA offers slight advantage when it comes to immunity, recovery, and environmental aspects. But robust and compelling data are required in the future to substantiate any assertion that anesthetic choice can meaningfully impact the tumor biology. And until more conclusive evidence emerges, the choice of the agent should be tailored according to the patient, considering the comorbidities, the risk factors, and the tolerance of the overall anesthesia plan. So I would like to conclude by saying that we should all practice evidence-aware medicine, not just evidence-blind or evidence-rigid medicine. And the take-home point is patient's cancer biology does not pause in the OR itself. So as a perioperative physician, our vigilance should also not stop. It should not be limited just to the OT. It is a responsibility as an anesthetist that we should not just think about short-term outcomes, just like 1 day, 2 days in the post-operative period, we must think that how does our anesthetic technique, especially in cancer surgeries in future, will see for the 1 year survival or 3 year survival or 5 year survival. So that should be our envisage in a bigger research project. Thank you so much.
Thank you, Dr. Raghav, for that very intelligent and interesting study on the advantage of TIVA. And you have rightly yourself also talked about the limitations that more robust data is required, as well as the evidence is promising in favor of patients in the perioperative period, especially those who are suffering from, who are undergoing oncosurgery. What is your own personal experience working in oncosurgery center over the last 4 or 5 years?
So thank you for that question, sir. Yes, so still what I feel is that we ourselves are very much accustomed to using the inhalational agents. Sometimes we still in practice haven't brought the practice of using the TIVA, because who will load the 50 ml syringe propofol, who will set them. So it's easier to just change the dial concentration. So I believe there is a personal limitation factor on the part of anesthetists also, that sometimes we feel that it will be more technically challenging in few aspects. That is one point. So second point, which I feel is that because of the lack of evidence, we still do not know whether TIVA will be beneficial, because in many cases we feel when we start using, in my personal experience also, when I start using propofol infusion, there is sometimes tremendous fall in the blood pressure also with the infusions. We sometimes don't know. We need to have a proper monitoring with TIVA, that is BIS monitoring, which is a limiting factor in many places. At AIMS, we are able to do that, but I know that TIVA, the challenge with TIVA is that we need to have a proper BIS monitoring. So these are few of the factors which I feel in future, if we can work on it, then there will be more adaptability to the usage of TIVA. We must make the residents aware, as well as we should enhance our knowledge also, but we need definitely robust data to conclude that, okay, TIVA is going to be better than inhalational in the overall outcomes.
Right. Thank you very much. Over to Dr. Kaul, sir.
Thank you, sir.
Dr. Raghav Gupta.
Good evening, sir.
Good presentation. But one important point for presentation in these competitive sessions has to be that the author has not to disclose his place of work.
Right.
You are the first person who has disclosed that where you are working and where you are. And the judges become biased if you disclose your place of work and where it has been done.
Extremely sorry, sir.
And if you still are not sure about your results, that you have not started changing your practice at AIMS, what can be the effect upon the listeners and the audience?
I do agree to that point, sir. First of all, sorry for the first mistake. Regarding second, sir, we are conducting few trials at our institute where we are trying to see the effect. But what I observed in studies is that we need a large data to make a conclusive evidence, because the margin of difference is going to be very less when we compare TIVA versus inhalational. So majority of the studies are retrospective, and they are done in almost 4,000 to 5,000 patients. But to conduct such a large study prospectively, it has to be over a period of almost 5 to 6 years. So that is the biggest challenge I personally feel we are facing right now to have a conclusive evidence.
Thank you. Thank you.
Thank you, sir. Thank you, sir.
Sir, I want to ask one question, Dr. Raghav.
Yes, sir.
You mentioned that inhalational causes more cognitive dysfunction than TIVA, and TIVA is better. So in what aspects, what cognitive dysfunction it causes lesser in the patients, those who have been subjected to TIVA, than inhalational anesthetics, sir?
So, sir, especially with sevoflurane, if I would mention, it has been postulated to cause post-operative delirium, sir. When we are using only TIVA, especially in the form of propofol, so the studies have found that
I'm talking about long-term effects, sir.
Long-term effects, sir, I'm not very sure, post-operative cognitive dysfunctions, but early, definitely, it has been postulated in the studies that early postoperative delirium is less. I'll have to go through the literature to see that whether any long-term changes have been studied or not.
Right, so thank you.
Thank you so much, sir.
Yeah. So we move on to the last presentation for the day. I ask Dr. Gauri to please share her slides.
A very good evening to everyone. I hope my slides are visible.
Yes, please make them full screen.
Yes. Are they visible?
Yes, very good.
Thank you so much. A very good evening to all of you, and thank you so much for allowing me to participate in the second round of the RSACP Youth Conclave. Many, many thanks to RSACP for allowing us to giving us this platform. My topic for today is decision-making in anesthesia, to do or not to do. Decision-making is tough, particularly for indecisive people like me. When it comes to having a simple samosa, if the decision flowchart can be this complicated and if this decision can be so complex, imagine how tough life is when we have to make decisions in anesthesia every single day. From the point of time that a patient walks into our PSC clinic to the point of time that they are discharged from our care, we make so many decisions. What investigations to order, what kind of anesthesia to give, what is the plan for the anesthesia, what drugs to be used, what monitors, what kind of post-operative care. All of these decisions are very complicated. And they're important, right? Because they all have a marked impact on our patient safety. And what's the expectation from us? That each one of our decisions be good decisions, which are centered on the patient's well-being, and that they are done in such a manner that the benefit of the planned intervention or surgery be delivered to our patients. And this is an elusive component of anesthesia practice, right? This is something that we watch, we interpret our seniors doing it, we calibrate, we emulate. We never taught how to take these decisions. So how do we make these decisions then? Let me go over that with you. First and foremost, it's the impact of clinical findings. This is our basis as clinicians, as scientists. This allows us to establish a basic perioperative risk. And this is also something that we learn on the job. This is not something that textbooks can teach us all the time. We need to stay updated at all points of time. And this is what helps us decide which risks to accept and when to say this is beyond our care. Then you have the impact of traditional learning. This helps you form heuristics, which are mental shortcuts, which allow split-second decisions to be taken. For example, when you hear hoof beat syndrome, think horses, not zebras. If you have tachycardia, hypothermia, under anesthesia, immediately your mind jumps to malignant hypothermia, thyrotoxicosis, and the works. And you don't stop, you immediately jump to action. These help novices act quickly, but they're not foolproof, are they? Then there is more. As you grow, your past experiences begin to weigh you down. It is either your training and experiences or the lack of them, which leads to a bias in decision making. This definitely has an impact on outcome, but you have to remember that they allow the physicians to err on the side of safety. If something scares you, you're not going to do that. And all of this is weighed in the patient's safety. Whether it allows the full benefit of the intervention to be achieved by the patient, that's debatable. Then there is the impact of available literature. Available literature can be in the form of guidelines or research paper. Now, guidelines are produced by societies, so they tell you the best practice advice, but they're not tailored for individual patients. Research papers are a different ballgame altogether. In order to utilize these perfectly, we need to understand the quality of evidence, which is that randomized control trials, systematic reviews, and meta-analyses form the best kind of evidence there is. Reproducibility of literature and feasibility of this evidence in our infrastructure is extremely important. Then you move on to the impact of patient preferences. This shared decision-making is not just fancy terminology. When there is no best medical choice, we can help our patients become more autonomous, take their preferences into account, provide them the information they need to make an educated decision. And then there are influencers. I'm not talking about the social media influencers. When I have to take all of these decisions, there are certain influencers, like what are the resources and infrastructures I have? What is it, how much of fear of litigation do I have? How difficult is this patient and how difficult are the relatives? What are the kind of administrative pressures that weigh me down? What does my surgeon want? And these tend to impact the kind of decisions I make, which are apart from what my scientific, my rational, and my clinical mind knows. And how do these influencers impact me? Even in the aviation industry, there is an acronym called PAVE, which says that your outcomes are dependent on what the pilot does, the aircraft does, what the environment does, and the external pressure does. For anesthesiology, it is the same. Unfortunately, these influencers lead to defensive practices coming in, and also they allow heuristics to settle in, taking away the impact of the clinical mind. Are good decisions important? Yes, because good decision making has led to decrease in anesthesia mortality from 64 in 1,000 to less than 0.4 in 100,000. How is that? We understand physiology better, we have better monitoring techniques, we have safer drugs, we have better technology, and much better technology guidelines. And how much have we done this? We've reduced the incidence of errors by 1 million incidents per year in 3 years alone. And this has saved $7.7 billion. But at 115 incidents per 1,000 hospital admissions, the incidence is still too high. It costs patients around $8,000 per admission, which is quite unacceptable. So clearly, we can do better. And if we're doing good, what happens when we take bad decisions? When you take a bad decision, it sets off a bad decision cascade, where your initial poor decision increases the probability of a worse decision because you're so stressed and you're likely to be fixated on the poor decision you've made. As the cascade progresses, your safer alternative decreases. The case of Elaine Bromley has been an example to us about how fixation and stress leads to bad decision making. When you're in a bad decision cascade, can you work your way out of it? Absolutely. You replace the problem solution with a solution cycle. So here, I recommend that you stop, you call for help, you consider other alternatives, and engage in active problem solving. For all of that to happen, make sure you eliminate the noise. All of the people screaming for your attention, the surgeon asking you how long you're going to take, your pressure, and is this going to take too long? Your patient comes first. Your mental health comes first. Stand aside, look at your decision, see something is going wrong, and then rethink your way into a solution. Can we learn to make better decisions? Of course. We need to just change our targets. First, target the rationale instead of behavior. Our anesthesia training is usually hands-on, right? So we ask our residents to look at us, observe, and emulate. Rather than the actions, maybe we could teach them the rationale behind the actions. For instance, saturation drops increase the FiO2, yes, but instead of that, if we could teach them a systematic approach that they could follow every time they see desaturation, maybe when they're alone in an emergency, they'll do better. When you probe into the rationale, it'll unmask latent errors. If you ask them, what do you think I did this for? Maybe they'll be able to explain it to you better, and you can correct them as you go. As an individual, you can employ cognitive self-monitoring strategies. Specifically, deconstruct preconceived notions, deliberate conscious decisions for alternatives. You can use the 3P approach, which is perceive, process, and perform. I see bronchospasm, I process there is a problem, and then I perform strategic steps to correct it. In that, you could also have decide or the rule of 3, which are certain other strategies which will help. You could use external decision support tools. This is a method that I endorse heavily because I really like how it takes the burden away from your mental faculties, which are already stressed and strained at that point of time. And something that's so easy to you just doesn't occur to you because of the mental block. Similar to an exam, but clearly this is much bigger, right? There's a patient's life at stake. This would include your checklists, your algorithms, your protocol. It will reduce the effects of non-rational cognitive factors, your stress, unfamiliarity, this and that. Like for instance, imagine if you or me were stuck in a malignant hypothermia. Luckily for me, and I'm sure luckily for you, you've never faced it. What do you do then? What if I get confused? What if I lose my way? If I had a written support tool, it would make my life so much easier. If I can create a sense of familiarity, a sense of routine, then everybody in the team is on the same page. And you create an additional layer of defenses to prevent errors. To summarize, good decisions come from experience, and experience comes from bad decisions. Hopefully, we can create a template where we can create decisions without necessarily experiencing these bad decisions ourselves. Thank you so much for the opportunity.
Thank you, Dr. Gauri, for such an interesting topic. And I'm really very happy to note that all the speakers have chosen so different topics talking about the advanced research and to the human emotions and day-to-day behavior in the OT and in life. And yes, decision making is very, very important, and you've taken a good decision of presenting this topic to us. And I've always found you a very good orator. So God
Thank you
bless
so
you.
much.
You've got a good future ahead.
Thank you so much, sir.
Dr. Kaul, sir.
Very good topic. Very impressive.
Thank you so much,
And
sir.
all the best. All the best. Very well presented. Novel idea and helpful, should be helpful to every person. Thank you. Thank you
Thank you
very
so
much.
much, sir. It means so much coming from you, sir. Thank you.
It is so good, Dr. Gauri. We have seen topics ranging from anesthesia to Bhagavad Gita to life challenges. I wonder what this youth conclave would lead on to next. It was wonderful. Thank you very much.
Thank you so much, sir. Thank you.
So I think we have listened to all the orators and Dr. Kaul and Dr. Singla, and I need some time to decide the
Dr.
best among.
One of the participant has not, Dr. Shashi Singh.
Sir, she
She's
conveyed
unwell.
leave of absence.
Okay.
She has already conveyed leave of absence, sir. So
The results are to be disclosed at the annual conference at Indore or today?
Sir, I think if we all, me, you, and Vishal will need some time to sit together and finalize, because we have to choose the best amongst the best. So we will announce in very, very shortly.
Today itself. Today
itself, sir.
No, I don't know. I leave it to you, to the
No, sir.
organizer.
I think today is maybe with the next webinar when we come, and in the website also, and social media also. So, but yes, as Dr. Kaul sir has said, we'll have a winner as well as a runners up also.
Yes, must be.
And
That was decided before the start of the competition.
Yes, and
before anybody presented. So it is not, it is unbiased that we want to have to one the winner and second the
so
runner.
I think we will sit amongst ourselves online and decide the winners and convey. I think not later than 1 week. So
Thank you. Thank you.
so God bless you all. Whosoever is winner, whosoever is runner up. But for us, all of you are winners.
All are winners. All are winners. Everyone presented nicely.
And if with the permission of Dr. Kaul, I can say that one of you will be the RSAP Youth Orator 2025. We will be delivering the youth oration at RSAP Con 2026 at Indore. But all of you who have presented today will be invited faculty, will get a faculty position during the RSAP Con 2026. And that is, you can award or reward for presenting in the finale. And in addition, all of you who have scored the ranks in the first round will get a certificate, a medallion, yes, as I committed, and a cash prize of 10,000. The winner gets the 25,000 cash prize with an opportunity and honor of presenting as the Youth Orator 2025. And the runners up will get a cash prize of 15,000. And both of you, the winners and runners up, will be the coordinators for the RSAP Youth Conclave 2026, along with Dr. Neha Sinha, Dr. Neha Mishra, Dr. Tanveer Singh, and Dr. Nitin. So the first winner and runners will the youth coordinators for the 2026 Youth Conclave. You will mentor them, and and uh, as I said earlier, all of you will get a faculty invite for RSAP Con 2026. With this, I thank once again my judges, our patron, Professor Tejki Kaul sir, dear Dr. Vishal Singla, the Honorary Secretary, and very proud of Dr. Tanveer Singh. Dr. Tanveer, if you can switch on your video, and you have been arranging the things. A few words from our uh, coordinators, the national coordinator, Dr. Tanveer Singh, and Dr. Neha Sinha, and Dr. Swati, thank you for your comments. I'll invite you also, our Joint Secretary, Dr. Swati Chavda. Tanveer.
Hello, am I audible, sir?
Yes, loud and clear.
Yeah, thank you, sir. Good evening, Call sir. Good evening, Dr. Naveen sir, Dr. Vishal sir, and all the participants. And as expected, hello, hello. Sorry. And grand finale, I knew that all the participants were so good, and it will be all the judges will be having a tough time to judge the participants. But as in every competition, we have to give first and second, so it's be deciding upon that. And as Naveen sir has been always generous, and this time also he has generously given the faculty positions as well as the cash prizes to the runners up. Thank you so much, sir. It is because of your guidance. It was your brainchild that you asked us to execute this. And thank you for all. Thank you from everyone's side that we have been able to do this. It was really great. It has been really all council who have supported us wholeheartedly. Thank you, sir. Thank you.
Thank you, Tanveer. And I look upon to you and your team to continuously keep on mentoring the next Youth Conclave 2026 also. Dr. Neha Sinha, uh, the RSAP National GC member in the capacity as youth representative as well as the national coordinator for the Youth Conclave 2025.
Thank you very much, sir. As I always say, I have been very fortunate enough to be have mentored by you all the time, being guided. And I guess that's all that I have learned, and I am able to project it now. But more than that, I would like to say that this youth conclave, was just not a competition that we have made it to be. It was more of young minds presenting their ideas, their youth voices, their leadership ideas, their innovations. And more than I think presenters, we have found good friends over here as well, and so many young and awesome anesthesiologists are there in the country that we need to find out more and more and give them positions of importance. So I think it was a wonderful, wonderful platform and a great initiative from you, sir. And thanks for believing in us. And we could do this well. And we have good presenters and good people around us now. Yes, our anesthesiology looks like it's in the safe hands. Thank you so much, sir.
Thank you, Dr. Neha. And the best thing which I heard from you is that we have got plenty of very nice anesthesiologists, young anesthesiologists, whom we have to give positions. So it's good that you have taken a position and you're searching for the persons who are able and competent who can take up the positions in future.
Teamwork, we all need teams.
Great, great. I appreciate that. Nitin?
Thank you, sir, for this opportunity. I think, as Neha rightly said, that we got to meet some real great talents during this search, during the youth conclave. Other than that, we also learned a lot. I mean, some of the topics were like totally, brilliant. And I just wondered from how did they get this thing in their mind and how did they finally got down to this topic. So it was really encouraging. And I think we learned a lot from them and they encouraged us to sort of drill our minds to come out with even better things in the future. So I think we have the talent. We just need to provide opportunities. You have been kind to all of us. You know me from my PG and SR days, and you gave me wonderful opportunities, and you were always a strong pillar to support me in all my endeavors. And I think that's how you have brought us up, and we are here along with you supporting the others. I think it's brilliant. It's a great idea, and thank you so much. And I thank on behalf of all the youngsters for coming up with this idea. It's really amazing, and thank you so much.
Thank you, Dr. Nitin. And I must, before I invite Dr. Swati Chabda for our joint secretary and the national coordinator for RSAP GOCP editorial fellowship to propose formal vote of thanks, I must place on record that Nitin holds a very unique record of winning the maximum number of awards in the competitive session during the RSCP con, the medals as well as the cash prizes. I think he became member in probably 3,500 or 5,000. He must have won around
5,000.
5,000,
sir.
5,000. So he must have won awards worth. Awards have got no value, but financial prize also at least 20 times more than the membership. So I wish someday you will choose somebody or teach somebody or mentor somebody who will break
Definitely.
who will break your record. God bless you.
Thank you so much, sir. Thank you so much.
So, Dr. Professor Swati Chabda, our joint secretary, over to you.
But sir, before I propose the vote of thanks, I would really like to congratulate all the speakers. It kept me glued to the Zoom meeting. So heartiest congratulations to all the speakers, the chairpersons, the moderators who have very nicely steered them through asking questions, making comments and compliments. That was a learning point in itself, and the national and state coordinators. So I have to thank them also later on, but first, heartiest congratulations to everyone for being this Youth Conclave finale. So now to propose a vote of thanks, as sir said, so I would really like to thank, first of all, the patron, Dr. Tejke Kaul sir, who has over the years mentored so many and nurtured future mentors, so that we are blessed with each generation of anesthesiologists who are quite passionate about the society and its progress. So heartfelt thanks to Tejke Kaul sir and Dr. Naveen Malhotra sir, who is always there, come what may, always actively participating in each and every activity of RSA and beyond as well, guiding and inspiring others. Thank you so much, sir. Thank you, Dr. Vishal, for being there as a pillar of support. And I'm amazed that the kind of knowledge, sir has always told that you are 4G, 7G, but kind of knowledge you have across the fields, you're reading books, of course, very excellent anesthetist, pain physician. You're a truly all-rounder there. Thank you for your insights. And I thank all the coordinators, our Neha Sinha, Dr. Tanveer Singh, the national coordinators, Dr. Nitin, and Dr.
Neha Kumar. Neha Kumar.
Yeah, Dr. Neha Kumar. Thank you so much for getting this all, putting it all together, going through all of, plannings very actively on the platform, on WhatsApp, and then executing it so well on all the sessions and coming up to this finale. Thank you so much. And first and foremost, all the participants from the initial rounds to this finale, it's been spectacular journey, and congratulations and heartfelt thanks to everyone who have presented. Maybe they have won or not. It's been a great show throughout. And audience, thank you for sticking up till late, for attending and applauding all the presenters. Thank you so much for making this possible. And also, I would like to thank the office team of RSA, who are always supporting, providing the support in day-to-day activities of RSA. Thank you. And we'll meet again very soon on webinars and in person at Indore for RSAPCon 2026. Thank you very much.
So thank you very much. With this, we come to the conclusion of Youth Conclave 2025, and it marks with the beginning of the next journey towards RSAP Youth Conclave 2026. Thank you very much. Long live RSA. Thank you. Good night.
Thank you.
Long live RSA. Good night.
Long
Good
live
night, sir.
RSA. Long live RSA. Long live. God bless you all. God bless you all.
Thank you, sir.
Thank you.